I love you guys. Thanks for coming. We're so excited to have you back.
I know it's nice to have faces and not be talking to my 3 monitors. Well, yeah, because I have 2 and then I have this up. So then I see what you guys see. I see the chat and then I see like what you're seeing there with my notes and the next one. But I can close this and just have the 2. It's just a little tricky to toggle when there's only one. There we go. Okay, a couple of announcements. With all the technical stuff this morning, I haven't looked at the test yet, so I don't have an average, but I will get one for you as soon as I can. And Vicki will be looking to see if there's anything that we need to drop. And we'll, oh my heck, silence your phone, Chantel. And I will make sure that that we get that information to you, okay? Then Friday at 9, so this Friday I'll do the same thing that I did last Friday. I'm just going to do it from home because I'm actually off that day. I took the day off, and so just that morning at 9, I'll get on and do a quick question and answer from the lecture today and tomorrow. And I'll record it for those of you guys that are in clinical and stuff that you don't have the opportunity to be there. But if you do have a question that you want answered, then text me or tell somebody else that might be on the call so I can make sure that it gets addressed. No test next Monday. Because cardiac spans 2 weeks, we will finish tomorrow's content on Monday and start our peds heart stuff. And then that will go into Tuesday. And then Vicki will finish the day on Tuesday. So sorry, you have me Monday, Tuesday, Monday, half of Tuesday for all of cardiac. So it's kind of long. Hang with me. It's a lot, but we'll make sure that we get it understood. At first, you guys always give me this deer in the headlights look, like what's happening with this lecture. But I promise you it comes really well. And we'll do lots of practice strips for the ECGs. And we'll do lots of, who's laughing? I haven't told my.
Doesn't sound like a fart.
Oh, it's like I haven't told my joke yet. So make sure that you just hang on to that laugh for a minute, okay? Okay. And then quiz tomorrow at 8. If you come to the classroom, it'll be in here. If you're going to take it online, Stacy's going to get that all set up to be able to do that too. It's like 10, 15 minutes. And then we'll walk through the answers here. There won't be a review online. Okay. So we'll just go through the answers here. And then the heart sounds assignment will open up today and it will be due by Friday. But it's on the same site that was the breath sounds. And I found out like the day that it was going to close that they revamped their site and then it was not the way that I had set it up. So I apologize. If the heart sounds on that site are giving you trouble too, please go on the internet. I will try between now and then too to find a good site. But YouTube, some of the easy auscultation kinds of things for your murmurs, your S1, S2, S3, S4, some of those things that we talk about here in the assessment and starting in the ECGs, okay? Then I think that's it. Is there questions from this morning? Oh, exam 5, I didn't finish that thought. The test isn't Monday, it's the 19th. Okay, so that'll be exam 5. And I'll remind you in an announcement and stuff so that you don't come thinking that you have to take a test Monday and just to be very excited or very sad, I'm not sure, that you don't have a test. All right. Okay. Do you guys have questions on, can everybody hear me okay? My voice just doesn't project real well. So if you can't hear me very good, come down forward, okay? Okay, so you ready for a joke? It's so fun to have somebody in person, but see, the pressure's on because now you really have to laugh. You can't just be at home and be like, well, I don't know. I'll type in the chat, ha, 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 yes. Okay, so there's this lady and she has a set of twins, but because of her life circumstances, she's not able to keep them and she puts them up for adoption. And one goes to Mexico and they name him Juan. The other one goes to Egypt and they name him Amal. Well, years and years later, Juan finds his mother and sends her a picture and a letter and everything. And she's so excited. And she goes to her husband and says, look at this. I've got this picture of Juan. I wish I really had a picture of them all. And he said, honey, they're twins. If you've seen Juan, you've seen them all. Thank you. Did it just take you a second to get that? Or are you're just patronizing me? Okay. You knew what was coming? Did you really?
Yeah, the minute you said Juan, I was like, it's one of those.
Oh, it's one of those. Okay. All righty. So our objectives for the heart assessment piece is review the anatomy and physiology of the heart, including the electrical conduction system, and identify components of a cardiac assessment. Is that in your way? Can you guys see that okay? And I'm probably in your way, sorry. They said our podiums were supposed to be over here. All right, so anatomy and physiology of the heart. So you have your layers of your heart. With your pericardium, it's the outermost layer. It's the protective layer of the heart. It has 3 or 4 different breakdowns here. Your fibrous pericardium, parietal pericardium, visceral pericardium, and then the pericardial sac. So the fibrous pericardium is the most superficial. It's connective tissue that protects and anchors the heart so that with every beat, it's not moving all over the place, that it's anchored in there. The parietal pericardium is the sac that surrounds the heart and the roots of the great vessels. The visceral pericardium consists of the epicardium, so just epi is just above or just kind of the layer around it, and it comes in contact with the heart and the roots of the great vessels. So this is the sac around it. The visceral pericardium comes in contact with the heart. And the pericardial sac encloses the pericardial activity. You won't be tested on the amount, but it's kind of interesting to know that it contains 10 to 30 mils of serous pericardial fluid. So you've got fluid in that sac, but if they have too much is where they start to have some pericarditis or congestive heart failure and start to have too much fluid in that pericardial sac. Your myocardium is your muscle layer. So that's where the contractions come from. And the endocardium is the innermost layer. So there's a little picture here. You can kind of see the different layers of the heart. And when you've got, sorry, let me go back here a second. When you've got all of these different layers, remember that the great vessels come out of those layers too. So they're protected in and under this visceral pericardium and the pericardial sac. Okay, so your anatomy and physiology, just a quick little reminder, your AV valves are your tricuspid and your mitral valves. Those are your S1. Okay, so when those close, that's your first heartbeat. Your semilunar valves are your pulmonic and your aortic valves, and those are your S2. Okay, so you've got to have, I wonder if my pointer is working here. Oh, look. You've got your, and it might be just as easy here. So you've got your AV valves here. Let's see, where's my mitral valve? Right here. From this angle, I can't see it. Your mitral valve and your tricuspid valve. And those, when those close, then it prevents regurg of the blood from the ventricles back into the atria. Then when your semilunar valves close, the pulmonic and the aortic, it prevents the regurgitation of the blood back into the pulmonary bed or back out to the, from the aorta back into the ventricles, from the pulmonary bed back into the ventricle. Does that make sense? So they will keep them from the blood running backwards behind that valve. The cardiac chambers are your atria and your ventricles. Now your atrial kick, when you have this vessel or this valve open, then you've got passive filling from your atria to your ventricle. And same over here. When that atria contracts, then you've got what they call an atrial kick, and it shoves more blood into that ventricle before that valve closes. So if you're having problems with your atria not beating like they're supposed to, like atrial fibrillation, where it's just fibrillating and it's not actually contracting and beating, then you're not going to have that atrial kick where you have a lot of blood flow in that ventricle, and it'll decrease the cardiac output. And then your ventricles. Those are the big chambers at the bottom. So your coronary arteries, they arise from the base of the aorta. So you can see right here and right here are where your coronary arteries come from. Your right coronary artery feeds the right side of the heart and the inferior portion of the ventricle, of the left ventricle. So you've got that coming down here, the SA and AV nodes. Your left, sorry, that's your left. It's coming down the right. Which way am I? And then the left one is your widowmaker. That's the one that if they have plaque buildup or they have a heart attack that's involving that blood vessel, mortality rate's very, very high. And then that feeds the left atrium, left ventricle, and the SA node. So you have your electrophysiology, your automaticity, conductivity, excitability, and contractility. So your heart muscle is very different from muscle all over the rest of the body. Electrical impulses are generated at regular intervals without neural input. So that SA node just fires. Your brain does not need to tell it to fire every single time that it fires. Conductivity is where that electrical impulse goes across muscle cell to muscle cell. And I guess you could kind of even flip these to excitability is the ability for it to respond to the electrical impulse. And then it's conducted all over the heart. And then the contractility is the mechanical piece. You can have electrical activity and no contraction. And that's called pulseless electrical activity, or PEA. So if you have a patient that's on a monitor, and we'll talk about this more with ECGs, but if you're looking at their monitor and you've got this great sinus rhythm and there's no, like their sats are in the toilet, it looks like you had this great reading and now there's no reading, not like the ski wampus, they're moving around in bed and it came off their finger kind of thing. There's like no breathing and their sats are in the toilet. You need to get in there and check a pulse and make sure that your patient is even breathing and has a pulse. Because sometimes if they have a really sick heart, sometimes the conductivity, the electrical impulses are just going around the heart and they're not actually causing a contraction. All right, your sinoatrial node, or your SA node, is right up here in your right atrium. And it's the pacemaker of the heart. It beats 60 to 100 times a minute. We like it there. That's where we love. And when we talk about our ECGs and we talk about reading the rhythm strips, we love them in that 60 to 100 range. Your AV node is here. Can you guys see when I turn around? You really can? Okay, because I feel like I'm like right here so that you can see. Your AV node comes down here. So your impulse, and I think my next, oh no, I thought it's on the next lecture. It shows the electrical conductivity, but basically it goes from the SA node to the AV node. And then it goes right through here, and this is the bundle of His. And then it comes down your left and right bundle branches and out your Purkinje fibers, out here around the edges. So when you have, if the SA node isn't firing like it's supposed to, maybe it's too slow, maybe it's not firing at all, the AV node will pick up and it will fire. It only fires about 40 to 59 times a minute. So the heart rate is much slower. So cardiac output's going to be less. They're going to start feeling really sick. They're not getting the outflow that they need to get from the cardiac output. Then the bundle of His. So if this isn't beating like it's supposed to, and you don't have extra spots in the atria that are kind of trying to fire and pick up the slack, then it's going to come down here to the bundle of His, down the bundle branches, and out the Purkinje fibers. If you have an impulse coming from the ventricles, it's a very sick heart. And it will beat 20 to 39 times a minute. So I put the 39 because if you hit 40, it kind of tips you into the next range. Does that make sense? 40 to 59 because we like 60 to 100. So just remember less than 40 for your ventricular, your bundle of His, and your Purkinje fibers. All right, we're going to see if Chantel can manage more than one thing at a time here with the videos. Okay, where's my, oh heck. That's the heart sounds. I thought there were two there. Never mind. That is basically a 3D. It's very cool, but it's just basic regular circulation. So before we go into this unit and we mess it all up with all of our Pete's heart anomalies and everything, I like to just show you kind of this 3D view. And so it's just 3 minutes long. You guys can watch it at home, or I can try and figure it out on the break. I thought it had it brought up on the bottom here. Huh?
Does your link not work?
Can you go over the link, hover over it, and then
And go back into this, and then I can, let's see if it'll go from there. I wasn't sure if it would go on my share my.
The heart is a muscle about the size of your fist. It lies
Can you guys
behind
hear
and to
that?
the left of your breastbone or sternum. The purpose of the heart is to pump blood through blood vessels, arteries, and veins to all parts of your body.
No.
The inside of the heart is divided into 4 chambers.
I don't think we button.
Is
The
it?
top 2 chambers are called the atria and are collection chambers for blood. The bottom 2 chambers are called the ventricles.
Well, shoot, I'm not sure why it's not doing that when I'm already sharing my screen. So I can try and do that on the break.
If you go out of presentation mode and try clicking on it when it's not in presentation mode, it might show up.
Okay, let's try that.
The heart is a
No.
muscle about the size of
Exit
your
out of
fist.
Presentation mode on your PowerPoint.
Okay. Come on. There we go.
And then just try clicking on the link like that. Where it is.
Well, it won't be a hot link unless I'm in presentation mode. Does that make sense?
If you hover over the link, and press Control and click it at the same time.
Control and click it.
There you go.
The heart is a muscle about the size of your fist. It lies behind and to the left of your breastbone or sternum.
There we go.
The purpose of the heart is to pump blood through blood vessels, arteries,
Okay.
and veins to all parts of your body. The inside of the heart is divided into 4 chambers. The top 2 chambers are called the atria and are collection chambers for blood. The bottom 2 chambers are called the ventricles and receive the blood from the atria and pump it to the lungs and the body. The chambers are separated by valves, which control the direction of blood flow. There are 4 valves: tricuspid, pulmonic, mitral, and aortic. Circulation begins at the right side of the heart, where blood from the body comes to the right atrium. This blood passes to the right ventricle, where it is pumped to the lungs to receive oxygen. Once it receives oxygen, it flows to the left atrium and then to the left ventricle, where it is pumped to the aorta and the rest of the body. On the right side of the heart, the tricuspid valve separates the right atrium and the right ventricle, allowing blood to enter the ventricle but not flow backwards to the atrium. Blood flows through the pulmonic valve to go to the lungs. On the left side of the heart, the mitral valve separates the left atrium and the left ventricle. Blood flows from the left ventricle to the aorta through the aortic valve and to the rest of the body. Arteries carry blood with oxygen and other nutrients throughout the body. Veins take blood back to the heart, which pumps it to the lungs to be oxygenated. The heart arteries, coronary arteries, provide oxygen and nutrients to the heart muscle. The right coronary artery supplies blood to the bottom and the back of the heart. The left coronary artery splits into 2 vessels. One branch supplies blood to the front of the heart. The other branch delivers blood to the left side of the heart. An electric system transmits signals throughout the heart to control its pumping. The electrical signal starts in the sinoatrial or SA node, which is located in the upper portion of the right atrium and is known as the natural pacemaker of the heart. The electrical signal passes down to the lower chambers of the heart via the atrioventricular or AV node, which controls the signals so the atria contract before the ventricles. In the ventricles, pathways carry the signal throughout the muscle so that they contract at the same time to pump blood to the lungs and through the body.
There are lots of, let's see here. Then I go back out, right? And then okay, there we go. Cincinnati Children's has, let me go back. Cincinnati Children's has a great site with some of those 3D videos for those of you guys that have pediatric heart anomalies for your presentations. That is a really good site to go to for information in general, but also for to put a little video snippet in your presentation if you want to do that.
What is it?
Cincinnati Children's Hospital. Boston Children's Hospital is another good one. Your online reading that I have posted in the cardiac module has a couple little sections, not a couple, it has a little section for every heart anomaly that we're going to cover and to kind of give you a jumping off point. You don't have to go into a lot of depth about the heart anomaly. Some of them require 3-step surgeries. Some of you can simply say they require a 3-step surgery where they, and you can just give us like a quick little 15-second overview of they reattach blood vessels, they reroute circulation, and those come at 6 months, a year, and 18 months or something. You don't have to tell us it's a Norwood and it's a Glenn and it's a Fontan and what each step of those is. Does that make sense? So you don't have to be that specific because that's not the nursing implications. Okay, those are surgeries. What we need to know mostly is that they're going to have surgery. So preoperatively, what are our assessments, right? And what we need to do to take care of that patient. If there is post-operative care, then leave that alone because that's a presentation by itself. Okay, so don't go into post-operative care. Tell us what we need to do, what we need to know circulation-wise, a little bit about the heart anomaly. And then all of those guidelines are also in the cardiac module right toward the top. Kim, I think you had yours printed out, the little one, it says cardiac guidelines, pediatric cardiac guidelines, I think, right? Yeah, and it's right toward the top of the cardiac module. Those are presentation guidelines that will help you if you have a peds heart one. Okay, so we don't have clickers all set up in here, so I just want you to kind of go through the question and don't look ahead at the answer. I think it just tells you, oh, it tells you the poll. It doesn't give you the answer. Okay. So the nurse caring for a patient with pericarditis understands that there's inflammation involving what? Oh, look. 4. So peri's around, cardio's heart, itis is inflammation. I had to give you some sort of rationale. I didn't know more rationale than that for that one. All right, the coronary arteries arise from, I can't switch sides. I feel like I'm like standing. Is that now I'm going your way? The coronary arteries arise from the one aorta near the origin of the left ventricle. Slide 6. So yes, it just refers you back to the slide so that you can go back and look at where the arrows are. All right, the pacemaker of the entire myocardium is 4, the SA node.
Yep.
Okay, located in the right atrium.
Yeah, I love the heart. It's my favorite.
The intrinsic pacemaker rate of the ventricular myocardial cells is
3. The ventricle, not the Purkinje.
So ventricles are bundle branches
Oh, is it?
and Purkinjes.
Okay, so it is good.
Bundle of His, even 2. So what is that? 4. You all right, which refers back to slide 8. Okay. So that blood may flow from the right ventricle to the pulmonary artery. Which of the following conditions are required? So it's a select all. Sorry, I forgot to put that up there. What's that?
It's too early for this. I can't even focus.
No, come on. So we're going from the right ventricle out to the lungs. So what has to happen? Yes or no? Yes.
Yes.
Because if that ventricle pumps and that's not closed, where's the blood going to go? Back into the lungs, right? We need it all to go to the lungs. Okay? Yes or no?
Yeah.
Yes, because otherwise it won't go to the lungs, right? If it's not open. Okay? Pressure less than the pulmonary arterial pressure?
That would be more.
Right. And the right ventricular pressure must rise. So we get all that blood in there, we close the gate, and now it can contract and go out to the lungs. Okay. All right, the first heart sound is generated by so that's S1.
Those are the AV.
Number 2, you are right. S1 is AV valves, S2 is the semi-star valves. All right, so your assessment, heaves, PMI, telemetry, palpate, lifts, and thrills. So inspect. Now you can inspect for heaves and lifts, but you can palpate for lifts.
What is the
And heaves.
difference?
So there really isn't a lot of difference. Some of it is in the circles you travel in, like cardiologists will differentiate a little bit, but basically you want to see if you have a really sick heart that is enlarged, then sometimes you are going to see a bigger lift or like heaves. If they're laying flat on their back and you can see their chest, you can see that heart beating. Sometimes that means there's hypertrophy, often of the right ventricle or the left ventricle, not necessarily the atria, but you will be able to see that better. But also on a thin person, you'll be able to see more of just like a whole lift as opposed to a heave is more of a beat. You can see it more beat for beat as opposed to like a whole lift of like the chest. Yeah. But it generally indicates that there is a problem with the heart unless you have a very, very thin person. Generally a male, so there's no breast tissue that's in the way either. Then sometimes you can see that a little bit. But a thrill, you will always feel. So it sort of rhymes. Okay, and a thrill feels like the throat of a purring cat or like a washing machine, and it just feels turbulent in there. That's generally indicative of a murmur. When you've got, so those kind of travel together. You will also feel a thrill when you've got a fistula for dialysis. So always make sure you listen to and feel a fistula for dialysis. Yes?
This might be a stupid question, but like when you're palpating for the thrills on the heart, where are you touching?
Generally PMI, because you will be able to feel, if you have a smaller murmur from the top, you will be able to feel tricuspid or mitral down toward the PMI. And so if you have a very large breasted woman, then you just need to ask them, is it okay if I hold the breast tissue out of the way? I need to put my hands here for a minute and palpate. Yeah, throw it over both of you guys at the same time. Throw it over your shoulder. Hi, Dylan. And be able to palpate there and just hold your hands there. You won't be able to, it won't be very long. You'll be able to feel it. I think that's funny that you guys did that at the same time. And then telemetry is just when you hook them up to their leads and you're watching it like out of the nurse's station or whatever. I'm going to show you the leads in our ECG one, in our ECG lecture next, that will show you the differences with telemetry leads and ECG leads. Okay. We got started way late. We had technical problems. So, so sorry, you were going to catch us right on our break. So when you auscultate, you want your rate to be 60 to 100, your rhythm S1 or S2. With your pulse strength, you need to classify it. So I've noticed this with some of the concept maps that I get for my group. They'll say pulse is present. That is grand. You always want them there. But I need you to classify it. So tell me if it's strong, or if it's weak, or if it's bounding, or if it's thready. Okay, so classify those pulses when you do your assessments. Capillary refill time, you guys know that. Just make sure that you're charting it for all extremities. So you can put that the capillary refill time was less than 3 AE, which is all extremities. Or if it's bilateral upper extremities and left lower, but the right lower was, maybe they had a cast or something and it was slightly delayed, make sure that you differentiate. Edema, same thing, all extremities, or differentiate if one limb is different. And then the blood pressures, anybody want to tell us what orthostatic blood pressures are? But not in that order. You go the other order.
Lay down,
Lay
down,
and standing.
2 minutes in between each. Yeah.
Wow, so you have a minute to compensate. So, and actually you said 2 minutes, because I thought it was a minute.
I don't know, they taught me 2 minutes.
Oh, okay. Is that something new that you learned? Because we had always done it at 1 minute, so I don't know. Best practice sometimes changes.
I don't know. That's probably the hospital.
So if you're doing orthostatics, just know that you don't lay them down, take their blood pressure, sit them up, and immediately take their blood pressure again. You got to give them a minute to compensate. But you will find if it's dropping when they're sitting, then be really careful when you stand them up and make sure that you're here and you're ready to set them back on that bed. Okay, if they start to crump on you. All right, your auscultation sites. So your aortic, pulmonic, herbs, tricuspid, and mitral. So you guys know these sites. Just make sure that you remember they coincide with where those vessels are and where you're going to hear those sounds the best. So if you're auscultating mitral, then you're not going to be listening here, right? Because that's down here, base of the heart. The aorta comes off, you're going to hear aortic, pulmonic, you're going to hear those up here. And then as you work your way down, then you're going to hear your valves more down here.
What is herbs?
Okay. What does herbs stand for?
Well, like, what is it listening?
I do not know unless it's the person who came up with that spot. They often get their name put in things if they come up with it. All right, your heart sounds. This little video just has S1 and S2. What's that?
I was like, I found this.
I found this. This has your S1 and S2. If you're not sure what just S1 and S2 sound like, then before you go on to listen to murmurs or anything, just listen to S1 and S2. And then when we get to S3 and S4, these are going to be, so when you look at your heart sounds on the site that I gave you, if those don't work and you need to find them on YouTube, I want you to do S1, S2, S3, S4, and systolic and diastolic murmurs. Okay? Those will help you the most. So your S3 is what they call a ventricular gallop. And you can kind of see right here, oh, no, wrong button, right there. Where it goes love, dove, D. Like it comes quick off there. So you might have this kind of rhythm and they're going along and then all of a sudden it's right after the second one, okay? It's early rapid filling of the ventricle. That's at the beginning of diastole. So diastole, we're going to talk more in our ECG lecture in a minute, is more of your resting period, okay? Refilling, relaxing, we're getting ready, okay? S4 is an atrial gallop, and it comes right at the beginning, right before S1. So it's like D, love, dove. And then you might hear love, dove, D, love, dove, dove, love, dove. Does that make sense? So if you're musically inclined, it's very helpful. All right, your murmurs, systolic and diastolic murmurs. Systolic murmurs are very harsh, high-pitched sounds, and it has the sh in the middle, so love, sh, dove. And you will find the harsh, high-pitched sounds often with more of your ASDs, like higher up in the, if you have an atrial septal defect, then that is more of a harsh, high-pitched sound, indicative, very similar of a systolic murmur. Your diastolic murmurs are softer and lower pitched, and that can be also if they have a ventricular septal defect, where it's down in in between the ventricles and that part of the septum. And that one is at the end. So it's love, dove, shh, love, dove, shh. So then when somebody says, here, come and listen, they have a heart murmur, then really listen to where that shh occurs so you can see if it's systolic or diastolic. All right, so that's the heart assessment one. We'll take a quick 10-minute break and I'll load up the ECG one. That's the next one that's loaded there under your cardiac PowerPoints. It's green. And let me see if I can make I can't make my lights go up without just putting it here. Why not? Okay, if you need to go to the bathroom, out to the right, and then at the end of the hall, a right, and it'll be on your left. Right, left. You'll see the sign once you go right, you'll see it on your left.
Like I still put forth the same effort I've always been putting forth.
I don't think so.
And so I was just like
What's up? Probably all my calories. I got there. Erase those calories.
yeah, and I was like, we're not going here. Yeah, they're gonna make it over
Yeah, they tore up everything.
I couldn't find the
Sweet. 3:30 still, right? Well, I think my parents pick them up. But we're not fans of our children. So we got no sleep last night. This is one thing after. Like they went to bed super easy, and then just all night it was like, I have to go potty, and then go to the bathroom. Then crap, man. Oh, it was we were up all night. Yeah, I want to lay in your bed. No, you can lay on the floor. Oh, I want to lay in your bed. No. And then no one else happens. Just lays on the floor. Like, why couldn't we resolve this 15 minutes ago? And then, and then 10 minutes later, I think it's bed. Just take it to the bathroom. Don't even every single night before a test is a nightmare for these kids.
At your house?
Yeah. It's like every night before a test it's been something. So I'm like, I'm already up to like 2 studying, and then the kids keep me up the rest of the day. So.
Oh, jeez. I remember.
I got used to it. I started drinking coffee around 10 o'clock at night.
Oh, no. And then when you have a chance to go to bed, can you sleep?
Yeah, I'm one of those, I can drink a cup of coffee and then go like right to sleep.
Really?
Yeah.
My boys can do that with like a Mountain Dew or something.
Yeah.
They can go right to sleep. I can't. I don't have a lot of caffeine intake, but when I do have some, it's later in the day, and I'll just be like, "What did I do? This is so dumb."
Yep, I'm one of the people. I'll be at somebody's house and they'll be having their decaf coffee for dessert. And I'm like, nah.
No, hit me with the regular stuff. None of this unleaded crap, right?
Yep.
Just have this much time left. I mean, like, it's been a long way. I'm sure it's a long It's nice. I tried to do, I did guitar for a little bit, but yeah, I just love the guitar. But like piano is good at night. I mean, it's hard to say, but it's easier to feel like interpret it. Oh, I know. I didn't practice very well. I've actually like for weeks. Yeah, and then I did learn that was actually what did you have? Maybe not. But like, you know what I mean? I write something like that. Because that's more I still want to play I would always It is so hot here. It's so cold. I'm not allowed to lean over it or else I would. I gotta stay like this. Okay. So.
Use your diaphragmatic breathing pattern.
Like the recital, and especially like
Step this up.
yeah, techniques, and then I'll stay Yeah, we have to keep reminding them. So they're at that age that like it's so far away. It seems like every day. Every day. I'm a little nervous too. I'm like you, like last night I was yeah, I started heading to that class and then I was like
I'm finding something.
literally saying like I I'm like yeah, I literally got even about patient care. She's just awful. And she always
It is like temperature change in here. It's humid and hot in here, and it feels so good out there.
We were trying to prop the door, but there's nothing to prop it.
What about this?
You're not gonna sit down at all?
Oh no. I like to walk. I would rather walk.
Like walk the aisle?
Yeah.
So, I guess you're mad at me now. So you used to be like, Dad's best friend.
And then we'll do one on this other side.
Best friend. Like, it's like, you were never my best friend, so I don't care. I got two best friends in this state. I got your mom and dad. I don't need you. You guys are gonna be so messed up. You're gonna be like, I just want your dad to hug me. Yes, you do. You're not meant to
like 20 hours long.
I don't even know how to say bad words. I mean, like, I'll say something and be like, I said bad words. How do you even know what's a bad word?
Oh, sorry.
Be able to find like.
Yeah, it's too simple.
I feel like we've got school. Like, we want to go over
Okay, Maggie's gonna try and see if she can turn that.
School they go to is actually teaching them
Oh, I- All right, you guys, let's get started. I keep walking right in front of that, and it's blinding. I keep going. Oh, whoops, still there. Still there. You know you're in nursing school when, right? So we have a new instructor. Her name's Debbie. You guys will meet her in farm. She's going to teach with Corby. But she's new to us. She actually went through our program years ago. Yeah. Anyway, she has penises and vaginas lined up across her desk. And she's numbering them. Because we got all new mannequins in the practice lab, then our old vaginas and penises they're obsolete, right? Because they don't fit the mannequins. So we are numbering them for a checkout system. So if you want to practice for final skills pass off, and you want to take home a vagina, you have to sign a disclaimer according to one of our faculty or staff members said, for medical purposes only. I was like, why do we have to do that? Why do we have to say something like that? So yeah, she's numbering them for a checkout system. Okay.
But we actually need those back.
Yeah, we actually want them back. I don't know. Okay. All right, here's our objectives. Hey, you guys. All right, here's our objectives for the ECG portion. Number 1, review the anatomy and physiology of the heart, including the electrical conduction system. Number 5, identify common dysrhythmias on patient cardiac monitor strips. Number 11, identify clinical manifestations and medical management of patients experiencing myocardial infarction or heart failure. And number 12, prioritize emergency nursing interventions for a patient experiencing an acute cardiac event. Okay, so this was a picture I was thinking was in the other one, but basically it's the same as the one you saw before. So here's your SA node. It starts right up there in the right atrium. And then your impulse will come down either of these branches to the AV node. The AV node, it pauses for literally like a microsecond. And that's where you get your P wave, and then you get this tiny little spot before your big QRS. That tiny little spot is that delay. And that delay allows the atria and ventricles to fill adequately before the next contraction. Then you have your bundle of His, and that comes right through here, down your left and right bundle branches, and out your conduction pathways or your Purkinje fibers. All right, polarization, depolarization, and repolarization. If these don't make a great amount of sense, a really good resource is your ECG book. And when you go into your ECG book, hey, how are you? 70? If we could do 70, I think it's at 72. I tried, I went down and then it didn't stay.
Is it hot over there? It is freezing over here.
So if you do 70, go to 70.
I'm like, what?
It's cold in this building.
Jack. Yeah.
No, you're
It's been 5 minutes there, they plucking the grays out.
And then as soon as that
commercial
screen goes
comes
off, it goes right back to the
That's
Oh, perfect. So it said yes.
So set it down a little lower,
Okay,
and then it'll flatten out.
okay,
So that's the actual temperature.
okay,
So
perfect.
set a little lower, it'll come down.
It'll come down. Thank you, I appreciate it.
Oh, fuck, this
They're all full of hot air, that's why. Or I am, or somebody is, right? Okay, so your ECG book has little colored tabs at the tops of the pages. Basic electrophysiology. So the very first colored tab, I think, is navy blue, and it says it's your anatomy and physiology. So some of the things that we've covered, those are pretty solid for most of you guys. The next one is basic electrophysiology, and there are a couple of paragraphs that go over polarization, depolarization, or repolarization. So if what we talk about here doesn't make like 100% sense to you, then go and read that little, it's a couple of paragraphs, and that might help. So your polarization, it's ready for action, it's resting. So this is your cardiac muscle, okay? It's polarized, it's ready. And the inside is more negative than the outside. So the inside, you will start to leak potassium out of the inner part of the cell at rest. Then what's left so your potassium is positively charged, right? And so what's left is more negatively charged ions. You've got some of your bigger proteins and things like that that won't cross that membrane unless there's an electrical change in that membrane. And so you'll be more negatively charged on the inside. So that's resting and that's ready. Now it depolarizes. There's a firing impulse from the SA node or the AV node or wherever the impulse came from. Okay, so somebody yelled fire and now it stimulates those cells. When those cells are stimulated, then it opens sodium, potassium, calcium channels, and you have this influx and change in your membrane. It's called your membrane potential. And then those electrolytes freely flow across that membrane. And so particularly your sodium and your potassium, and your cell becomes more positive. Repolarization is when it's recovering. So now we've fired, we've depolarized, and we'll talk about what that looks like on an ECG. And now it's recovering. It restores its electrical charges back to normal and becomes polarized. Okay. So just a little thing about your action potential. So we talked about membrane potential. That's the difference in the electrical charge across the cell membrane. So it becomes more permeable or leaky. Okay, and it can leak more of those ions across that membrane. Your cardiac action potential is the rapid sequence of voltage changes across the cell membrane. So that's what causes the contraction. And your membrane potential is more of your ions, okay, going across that membrane. So if you look at it like this, and this picture is in your ECG book, if you're more inclined, I guess, if pictures are a little bit easier for you. So the inside of the cell is very negative here. Now it's polarized. And we've got this change, this influx of potassium that's going across this cell membrane. And that makes the cell polarized. Then with the depolarization, that's where you get the stimulus. Okay, so then you've got these changes in the channels of the potassium and sodium that change here. And then when it's depolarized, your inside is more positive. So it gets the stimulus, then the membrane potential becomes more permeable, and then the ions are changed. So those little channels, those sodium and potassium channels, and even your chloride and calcium channels are all opened up like gates, basically, and allows those ions to go back and forth. And then it's repolarized, and it's back to resting, where the inside will become more negative. I think I have one more picture. Nope, I don't. So that's where the potassium starts to leak back out, and the inside will be more negatively charged. All right, so your electrical and mechanical parts of systole and diastole. In systole, the electrical activity of the heart, it's activated, the heart is excitable and depolarizes. Okay, so you've got this tissue that's ready to be ready to receive a stimulus. And then you have the action or the activation or the stimulus. So where the firing of the SA node, and it depolarizes. The mechanical piece of that the muscle shortens and contracts. So it shortens and contracts and empties. You've got that contraction comes down and empties the atrium ventricles. In diastole, the electrical impulse, it's recovering and repolarizing. So now the stimulus has gone and depolarized the cell. It's contracted, and now it's going to repolarize and recover. During that period of time, the mechanics of it lengthens, relaxes, and fills. So now those fibers that have come down and contracted, now they're going to lengthen back out, and they're going to fill back up. All right, arrhythmias and dysrhythmias. You will hear them both. Old school, I guess, more people that have done it for a long time often say arrhythmias, the cardiac arrhythmias. People that are more current or like newer doctors or newer nurses often use dysrhythmias more. Dysrhythmias is actually the more correct term. It's just an abnormal or disorganized rhythm, where arrhythmias is just like loss of rhythm, like there's no rhythm. This can have rhythm, it's just disorganized. So you will hear me accidentally use them interchangeably. That's why I bring it up. But most of the time I can remember to stick to dysrhythmias. Ectopic beats occur outside the SA node. That's any beat. Any beat that comes from anywhere in the heart other than the SA node is an ectopic beat. You will also hear it called ectopy. So they had ectopic beats, or they're having ectopy, which means they're having ectopic beats. All right, your ECG shows the electrical activity only, not the contraction. So it's possible to have pulseless electrical activity, or PEA. Always assess your patient. You will find me say that 100 times through this lecture. Always assess your patient. So if something looks funky on your telemetry strip, or you're out at the desk and you're like, wait a minute, that hasn't looked like that all day. I'm going to go assess my patient. Go put eyes on them and see what's going on. All right, this is a long lecture, so I stick some of these periodically throughout, just to give you a second to breathe. My son helped me find that one. All right, so for your ECG setup, an ECG represents the cardiac conduction pathway. You will often see, and I guess I put ECG setup, but it's actually like your telemetry strip. So it will be what you see out of the desk that's continuously going. So there's a 3-lead and a 5-lead. Your white, black, and red. Every once in a while it will be like a red, black, and green, but most of the time you'll see a red, white, and black. So the quick and easy way to remember how to hook these up, if your nurse hands you the 3 leads and says, here, go ahead and hook your patient up, is it's white over right and smoke over fire. And that'll help you remember how to hook it up. Now, if you have your 5 lead, it's still white over right and smoke over fire, but your clouds are over your grass. So your white is over your right, clouds over grass, smoke over fire, and chocolate's close to my heart. Okay. Or brown is last. So smoke over fire, clouds over grass, and brown is last, is how some people say it. I prefer chocolate is close to my heart. So that will help you be able to kind of line those up if they hand you the leads and want you to put them on. When you have your ECG leads, you will not have miscounted if there's only 10. There are 10 leads, but they do give you 12 views of the heart. That's why it's called a 12-lead ECG, not because there are actually 12 leads. So you will see them labeled, which is very, very nice, because then you can remember where they go. And you've got your right and left arms, right and left legs. Now, they don't have to be clear down on your ankles. They can be just down by their hips, just low, okay? They just need to be low. And then with your V leads, V1 and V2 are about your 4th intercostal space, okay? So right through here, 4th intercostal space. And then if you literally put 2, 4, and 6 right around, so 4th intercostal space, 2, 4 right below the breast, and 6 underneath the armpit. Then you can just put 3 and 5 right in between. Okay, so 1 and 2, and then 4, 6, and then 3 and 5 right in between. And you'll have it. When you look at your ECG, it'll come out with these little blocks with all different views, and some of them will look really foreign. We're going to look at the 2 lead. The 2 lead is the one that looks most, not normal, but the one that, well, yeah, normal. The one that looks like you're used to seeing, your regular P, QRST. That view is called the 2 lead. Sometimes when you look at some of your V leads, what is happening is it's measuring electrical activity between these different leads. And so sometimes you'll see it upside down. Sometimes you'll see it really small. So when you're looking at some of those V leads, it can look a little skewampus. Okay, so if you're ever trying to look at an ECG and you're like, wow, there's a lot of that, find the one that says 2. It looks like just 2 lines. Okay, and that'll be the lead that'll look most familiar to you. Okay, so you have your graph paper. So your ECG is going to come out on graph paper like this. And you've got your time and rate across the bottom and your voltage up the top. We're not going to do a lot with voltage as PNs. Okay, so some of that amplitude and stuff is how they turn up and down and where they want to see that land. So we don't need to worry about the voltage. What we are going to count is our seconds and our little boxes here. So you have 5 boxes in this little square. Each box is 0.04 seconds. So each of those is 0.04 seconds. So the whole box, or that right there, is 0.2. And it literally can be that small with your deflections for your P and your QRS and T. Okay, so when you look at these boxes here, you have a 3-second strip, and we are going to count. I'm going to give you always a 6-second strip. And I'll tell you why, because you want your heart rate in 60 seconds, right? You want your heart rate for a minute. And if I give you a 6-second strip, then you only have to times what you see by 10, and you'll have 60 seconds. Okay? So that'll be your counting. So when you look at that colored sheet that's black and red, that's the grid, and you see when it talks about your PR interval and your QRS, and it has time frames, that's what it's talking about, is these little boxes. When we talk about your P and your QRS and your T, we won't always refer to all of those numbers, but I will tell you which ones we will need numbers for. But I put them there so you could keep it for RN3, because they do use more of the, with heart blocks and junctional rhythms, then they will use the numbers on that a little more frequently. So we will do all of the sinus rhythms, all the atrial rhythms, and the ventricular rhythms. And then in RN3, you'll add on junctionals and heart blocks. Okay. All right. So 3 seconds for your little markers right up at the top here, and this is a 6-second strip. All right, so this is a normal or like familiar, I guess, ECG reading. This is your P wave, and this is your QRS complex. They call it a complex because there's 3 of them together, not just one wave. Your P wave is your depolarization of your atria. So when that atria depolarizes and it starts to have all those ions that change, and now we've received the impulse, we're going to depolarize and hopefully cause a mechanical contraction. What you're seeing here is electricity. It isn't contraction. That's why I say they can have pulseless electrical activity. You can be seeing this on your telemetry monitor, but they're not breathing and their sats are in the toilet. Like, what the heck is going on? Get in there and put eyes on your patient. Okay? Then the QRS complex is your ventricles depolarizing. So we'll break them down and tackle them one by one. This isoelectric line is kind of an imaginary line that goes straight through here. And anything that goes above is a positive deflection. And anything that goes below is a negative deflection. That's just terminology. I'm not going to ask you what is a positive deflection and what is a negative deflection, okay? Just so when I say there's a positive deflection, you know it's going above the line. And negative, it's going below. It isn't positive, good, negative, bad. It's just the direction. All right, so your P waves, your atrial depolarization. I'm going to go forward and backwards 100 times on these. I hope I don't give you motion sickness. So the P waves, that's your atrial depolarization. Remember me telling you that there was this little spot that's right here, that's that delay that goes through the AV node? That short little delay right there gives those atrial ventricles a lot of time to fill. So now your PR interval is going to go from the beginning of your P, clear over here to your Q, which sounds really strange because it's the PR interval, but the Q is the start of this QRS complex. Okay, so this is this little interval here. You will see in your numbers is less than 0.1 seconds. We are going to call it changed or unchanged. So when we start looking at a lot of strips, we are going to look at our P wave and that little spot there to see if it's changed or unchanged. And what I mean by that is you have P and QRS-T or QRS, and then you have P, QRS. Has our PR interval changed? Yes, because they're wider apart, right? And then we go back to our P, QRS. Has it changed again? Yeah, it's back to where it was before. And then what about now? Our P, QRS, that little interval right in between is changing, right? That can be indicative of a heart block if it starts to get longer and longer and longer, and then you have beats that drop and stuff. So it gets a little crazy with heart blocks. That's why we will call it changed or unchanged for us, but I put the amount of time in there for you guys. It normally precedes each QRS. Only one P wave normally precedes each QRS. So you'll have a P wave and a QRS. And that's what you want to see. And then when we get into atrial rhythms like AFib and stuff, we'll talk about what happens when you have lots of P waves. It's the same direction as the R wave. Okay, so we have the P wave is a positive deflection. The Q wave sometimes goes a little bit below, sometimes lands right here at the isoelectric line. And then the R wave goes up there. So the P and the R should go the same direction. It might not appear the same if the impulse originates outside the SA node. So your P wave is what that's talking about. Your P wave may not look the same. So if you're going along and you have, see this P wave? It looks like this P wave, right? And what was here may very well have looked the same. Those are all nice sinus P waves. They're all coming from the SA node. Now, if you were looking at a strip and you had all these nice sinus P waves, and then all of a sudden you had one that was kind of notched, or bunny ears or something, it's still only one P wave before your QRS, but now we're understanding that it's coming from outside the SA node. It's still atrial, right? Because it's still a P wave, and that's atrial depolarization. When you have, it repolarizes behind here. You'll never see atrial repolarization because it happens behind this huge QRS. Then the QRS is the ventricles that are depolarized. This is where they repolarize. So that T wave is ventricular repolarization. Yeah, Ken?
I don't know if it's really known, but your big blue button, they can't see what you're like showing on that.
They can't see my hand.
No, I don't know if you want to turn your computer so they can actually see like what you're talking about.
No.
What's going on.
Okay. So what are you seeing when you see? Do you see this?
Yeah, I see this right
You see it very good?
It's like at an angle, but it's better. Than
Can you see this?
I can see your hand though.
You can see my hand? So if
Yeah.
I point with my hand, it's better?
Yes.
Okay. All right, I can do that. Thank you for watching the chat on that. Okay. Okay, so atrial depolarization, ventricular depolarization, ventricular repolarization. Where does atrial repolarization happen? Kind of behind here, right? So we won't see it. So just remember, all this big stuff here is ventricles. They go big or go home, okay? So all of this. This was a U wave, but I'll tell you, in all of my practice, I think we thought we might have seen a U wave one time. And that was iffy. That was a cardiologist going, oh, I think I see a U wave. And we're like, I think I do too. You might be right, Doc. Okay, so we've got no P wave if the AV node or the ventricles originate the impulse. Okay, so if you have, oh, I went the wrong way. If you have no P wave here and you have just a QRS, then that did not come from the atria. And it won't be nice and narrow and beautiful looking like this if it's coming from the ventricles. It will be wide and kind of bizarre looking. Okay, so when we were talking about P waves coming from the same spot, up here, can you see that again? I'm only so tall. Okay, so on the left side of the heart in that yellow star is your SA node. If the impulse comes from there, then it originates, or then it has this P wave that's right below. The P wave that's right below there is nice and round, upright, just one before every QRS here. But now it's moved. So if our impulse here is coming from a different area in the atria, then that one may look different. See how it's very similar, but maybe this is just a little bit shorter and it's a little bit more narrow. It's coming from a different spot. Then you look here, then maybe it's coming from another spot. You still have P waves because it's above the ventricles. It's atrial. If it comes from another spot in the atria, then you're going to have a different looking P wave. So even a shorter PR interval here. Then if you come like here or here, all of a sudden you have an inverted P wave. And then another spot, then you have kind of these bunny ears looking right here. So you can see that we have a P wave before every QRS, but as they come from different places in the atria, they look a little bit different. That's called a wandering atrial pacemaker. And we'll talk a little more about it as we come a little bit further, but I put it here also because of the P waves. So you can see what happens when the P waves are there, they just look different.
Is the inverted P wave coming from the AV node? Is that what you said?
Sometimes. It can be junctional, it can be a little crazy, but you can have an inverted P wave that comes from the AV node, yeah. But often that is characteristic of a junctional rhythm. Yeah.
Are the inverted or the bunny ears necessarily a bad sign, or is it normal?
It's coming, well, you have different spots in the atria that are firing like they're not supposed to. So it's like, notice me, notice me, notice me, and it's not all coming from the SA node. So it can start to be a bad thing. If you have a random one here and there, it's not going to be an issue. But what happens is sometimes that electrical activity starts to get out of control, and then it can cause atrial fibrillation, where you have lots of little impulses coming from all over, and it's not causing good, solid contractions. It's more or less just fibrillating. And so if you start to have too many of them, then you don't have adequate filling time because they're kind of coming from all over, and you'll have decreased cardiac output. So that's where sometimes they will go in and they will cauterize different little spaces or little spots in the atria to keep it from being able to do that. And so it'll scar it, and then it won't have all these traveling impulses. So right off the bat, not necessarily a bad thing, but it can become that. Does that answer your question?
Yeah, so it's not something that like is a normal heart baseline and it just happens randomly to people. It's something that could indicate that it could cause something further down the road.
Yes. Yeah. It's not something that's normal that you want to see, but every once in a while you might see an ectopic beat or something that's arising outside the SA node that's there that might look different. But yeah, you're right. If it can be the beginning of something that could potentially get worse.
Isn't like reoccurring inverted P waves a sign of ischemic though? Or ischemia?
It's more T waves that you're talking about, and we'll get there. Inverted T waves.
You're right.
Yeah. That's okay.
I'm also sleep deprived.
No, you're fine. Did you say I'm dumb? Huh? Did you say I'm dumb?
I'm
Not
sleep deprived.
No, before that, I thought you said I'm dumb.
I don't remember saying that.
No, I think you did. You'll be in big trouble with me if you say that again. Because you are. You're here to learn. It's a learning thing. It's not because if you knew everything about it, I wouldn't have a job. So you need to be here to learn. Okay, your PR interval is atrial conduction of the impulse through the AV node to the ventricles. So right here, this little spot here is your PR interval. Okay, so it comes from the beginning to the end. And right in here is going to be the changed or unchanged piece that we will talk about. It's measured from the start of the P to the start of the Q, and it's normally 0.12 to 0.2 seconds, or 3 to 5 small blocks. Okay, so you've got your 0.04, right, is your teeny ones. And that becomes 0.2 for the little bit bigger one, for the small box. So teeny and small. And so it can go all the way through one whole box that has the 5 little boxes in it. It used to be that we would take calipers and we would measure and count all of the little boxes. But that's an ICU and cardiac skill and cardiac ICU and all of that. So that's not an LPN skill. So that's why we don't teach it that way here anymore. Years ago when I started, we did have a nursing instructor that did ask you guys to do that. And that's a little hard because it's hard to rationalize why you would do that because you won't right out of an LPN program work in a cardiac ICU. Does that make sense? So it's a skill that you can learn a little bit later. If it's a prolonged interval, then there's a conduction delay in the AV node. That can just mean that it's sick. It's a sick heart, starting to have some delays, starting to have some problems in different parts of the heart. And if there's a conduction delay here, then sometimes you will start to see that get wider and wider and wider, indicative of a heart block. All right, your QRS complex. So that's this, I have to point with my finger so they can see, this big part right here. Okay, that whole thing will occur together. It isn't always this far below and this far above. I just stretched it and enlarged it to take so you can see it really well. Sometimes it'll just deflect just a little bit and just a little bit. And it's very, very small. And if it's hard to see, then they will just they can turn up the voltage or the amplitude and kind of pull it a little bit taller. So ventricular depolarization and atrial repolarization is happening kind of in the background back there. It's measured from the start of the Q to the end of the S, and it's normally less than or equal to 0.1. So it happens pretty quick. It should be quite narrow. Happens really fast. So that's going to be here to here in 0.1. So if you're looking at these boxes, I guess it doesn't have the harder lines to it, but see how it starts just a little ways in to just a little ways in. And so as I've stretched it, I've actually probably made it a little bit wider than it should or would be if you just saw it on your 6-second strip. When you see them on your 6-second strip, and we talk about is it narrow or is it wide, then they will be very, very apparent. So when we start walking through our strips, if it's 0.1 or less, we're going to call it narrow. So when it looks like this is a very nice, narrow QRS. Sometimes it's not. So ventricular is wide and bizarre, and when we get to those, you will definitely see them, and you'll be able to make that correlation. Sometimes they will have a QRS that's narrow. It's normal just the way it should be, but it's just slightly wider, and that can be medication. And Corby will talk a little bit about medications that might cause an increase in a QRS or a QT. So from Q to T, it can widen that whole impulse, that whole section. And if you have a lengthened QT and it gets far enough, your T wave can land on your P wave. And that can be lethal. It could throw them into a dysrhythmia that's very disorganized. And they would end up needing to be cardioverted or shocked out of that. Okay. Q is the initial downward deflection, R is the large upward deflection, and S is the second downward deflection. Prolonged can be conduction from the ventricles. So if it's over that and you see it, when we see the pictures of them, you see a normal narrow QRS and a ventricular QRS, they are like worlds apart, okay? It's sometimes slightly wider in response to certain medications, but it will not look any different than the normal QRS that you are seeing right here. Okay, it'll look very much like this. Can't see it, the glow there on the clock. Okay. There we go. ST segment. Okay, so it's the end of the ventricular depolarization. So now we've had our atrial depolarization, and we have this little PR interval. Well, it goes clear through here, but the part that's unchanged, I want you to kind of look right through here. Your QRS, and then you have this ST segment, goes right heading up to your T wave. That ST segment is where we are talking about it's leading to repolarization. So it is not repolarizing until it gets to the T wave. This little section here, you want it to come right back to that isoelectric line. You don't want it to hang out kind of like a U shape and then come up. And you don't want it to shoot up here and then come down to a T wave. And we'll talk about what those mean. So it's the start of ventricular repolarization and recovery. You measure it from the end of the QRS to the beginning of the T, and it is stated as elevated or depressed. So if it hangs out down here and then it comes back up, then it's depressed. You have a depressed ST. If it shoots up like this and then comes down, then it's elevated. Okay? When you have, whoops, I'm the wrong direction again. An ST depression is coronary ischemia, and you will often see that coupled with an inverted T wave. So it's hanging out down here, and then you have an inverted T wave also, and those indicate coronary ischemia. They're coronary ischemia that isn't brand new. Now it could be just a few days ago, it could be months, it could be years, but something has happened and caused some damage to that cardiac tissue. If you have ST elevation, however, that's acute injury. It's happening now. And they call it a STEMI, and it's ST elevation MI. So you're going to see this ST segment. It's going to shoot up like this and come down to the T wave. It looks kind of like this. And my camera, kind of like this. That looks like what they call a tombstone. And that is exactly where they're headed if you don't intervene.
Great.
Okay, what's that?
Great.
Oh, no, yeah. So big intervention here. Contact your physician immediately. You need to get them, especially if you see it on telemetry, you need to get them an ECG. You need to make sure they have an IV. You need to start getting labs. They go into what they call a STEMI protocol. And there is a list of things that need to be done, and it needs to be done now. There's a time frame that they need to be in the cardiac cath lab, just as soon as you can get them there. And so always remember, and I think, I have a picture coming up, but I don't have a picture on the next slide. Just remember that it looks a bit like a tombstone. And if you have any question, grab somebody else that can look at it with you and get a hold of your physician and say, I think I see ST elevation on this telemetry strip. And so I'm going to grab an ECG, but I need you to come and take a look, or whatever physician is closest needs to come and see this patient. And then you can institute that protocol where you can go to your charge nurse and say, I think I see a STEMI. We need to get this patient IV access. We need to start getting labs. I need to get an ECG. That's your call. That's your patient. You can implement that protocol. The worst case is the cardiologist comes in and the physician comes in and goes, oh, no, it's just this or this or this. Well, now that patient has an IV and they've got a good set of labs and you can breathe deep. But I can tell you that most of the time when you see that you're going to be right on. It's very, very apparent. Okay. T-wave. So this is the ventricular muscle repolarization and recovery. It's not yet resting though. It's repolarizing. So now we're headed up there, and now here's our repolarization, and then we're going to rest, and we're going to have the atria depolarize again. Okay, so this is ventricular repolarization. It's measured from the start of the T to the end of the T. It's usually the same deflection as the R wave. I say usually because when there is a P wave and it's coming from the atria, then normal, I'll let you say normal right now, normal is that the T wave goes the same direction as the R. If you have ischemia, remember how I said your T wave could be inverted? If you go ST and then you dump like that for your T wave, that's coronary ischemia. You will almost always see it coupled with a saggy or an ST depression that's hanging out down here and then has a T wave that's also low. However, you can see that STEMI and then a T wave coming off here, or it can come right down and dip below. And you can have an inverted T wave by itself, which means they probably have old and new ischemia.
I assume it's hot here, so I'm just gonna hurry and turn this.
Oh, he turned it down to 68 because it was 72.
Feels great now. You guys are okay now?
Yeah, it feels
so
much
sorry.
better.
I could
No,
tell
you're
that
good.
there was like some circulation.
Circulation issues, yes. Circulation. Okay.
Is an inverted T wave only going to be of ischemia, or is there like another indication for an inverted T wave?
No, I guess there might be, but all that I know is that it indicates coronary ischemia. So do you know of another something that, or are you just asking?
I was just asking because I've had a stress test done before where they're like, oh, you have an inverted T wave. I'm like, what does that mean? He's like, it just means you're special. And I was like, okay, I didn't know any better. And now I'm like, oh my God.
So I don't know if that's something that you're born with, you always have, but I do know that there are dysrhythmias that are regularly irregular. And what that means is you might have like beat, 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 like every third beat for forever is that little beat. That is regularly irregular. Okay, so it's happening very regularly, but it's an irregular heart rate. So I don't know if that's something that maybe could happen. I don't know if that means if you have any little bit of coronary ischemia. Sorry to scare you. No, it couldn't mean anything else. Couldn't mean anything else. We're hoping you're on the too young side to worry about that. All right. they can be inverted or peaked. So where your ST depression and elevation, so backwards, ST depression kind of makes a little bit of a U, and elevation comes up. You're going to tell your peak, you're going to say that your peak or your T wave is inverted or it's peaked. When it is peaked, it is an electrolyte imbalance like 90% of the time. Okay, sometimes they might be special, I guess, maybe even 95% of the time. Anytime I thought I saw a peaked T wave, I looked at electrolytes and there was some sort of imbalance. So if you are ever questioning that, and this is looking kind of tall to you, look at your labs. Most of the time it will be your potassium, and most of the time it's hyperkalemia that's causing that. Now it can be magnesium, can be calcium. Sodium doesn't generally do that. Magnesium can a little bit more, but usually your culprit is your potassium. Okay, forward, back. I think we're forward. There we go. Electrolyte imbalance is specifically hyperkalemia. You can have, okay, so I just have a few extra arrows on this one. Ventricular systole or depolarization. Okay, so you have what's happening here. So you have your ventricular systole that's coming right through here where that's going to depolarize. Ventricular systole. So you've got your ventricular depolarization that's up here that's lasting through here. Then in the T wave, it's going to repolarize. Ventricular diastole is coming through here where it's repolarizing and resting. Okay. And then it just shows a little bit more about your ST segment being here to here and your T wave and your PR. All right, your QT interval, we won't do much with this, but when I try to dovetail it with pharmacology, there are a few things that I mentioned that kind of help set her up to be able to mention them to you. So a QT interval, you're going from the Q to the T. If you lengthen this, that's where you can come into trouble with the P waves that are happening afterwards. And those are often medication related. So the total time of ventricular depolarization and repolarization sequence, it measures from the start of the Q to the end of the T, and it's normally less than about 0.4 seconds. It's lengthened by some medications, and erythromycin is one of them. How often do we put people that have ear infections or pneumonia or whatever, and just slap them on erythromycin? Need to make sure before you put people on medications if they have a heart history. Because if they have a heart history and maybe they have a history of a lengthened QT, and then we go and put them on something like erythromycin, and we lengthen that further, we can end up causing more trouble. The ear infection or sinus infection will be the least of their problems, right? So far, so good. You guys hanging with me? Yeah. I promise it gets better. But sometimes before it gets better, it's a little worse, and then it gets better, I promise. So just hang on. We'll get some of this stuff down before lunch, and then we'll go like refill, take a deep breath, and then come back, and we'll keep going.
Is this stuff that's going to be on our quiz tomorrow, or is it mostly just the assessment stuff?
The assessment.
Oh, thank God.
Yes. The quiz tomorrow is assessment, your anatomy, physiology, and your heart assessment. So looking at your health assessment, what your cardiac assessment is, and then the one right before this that was the cardiac assessment PowerPoint. This one will be on the exam, not next Monday, but the Monday after. Okay. Yeah. Thank you for clarifying. Okay. All right. ECG interpretations. So you measure your R to R intervals on a 6-second strip. You can measure your P to P intervals, which should be the same as your R to R, but in heart blocks and junctional rhythms and some of them, they start to get longer, and then they drop and they do all kinds of wonky things. So we're not going to measure P to P because when you get into atrial fibrillation, you have lots of P waves. and it's literally impossible to measure that way. So we will measure R to R. So I can't read high enough for the for the people on the blue button, the top of the R waves. So from here to here to here. Those are going to be how we will measure. If this was a 6-second strip and we had 3 R waves, we're going to take it times 10 to give us 60 seconds. That is 30 beats per minute. Does that make sense? You have 3. It's a 6-second strip. If I just take it times 10, now I know that I have 30 beats per minute. So that will be, I will always give you a 6-second strip. So you can be confident in that. In the back of your book, it continues to count these few boxes. So if you look in the back of your book on this strip, it might say that it's 33. I'm not going to split hairs like that. It'll always be on the 10s. Okay? So if it says, if there's 10, you can take confidence in the fact that it's 100, and that there's not 3 more boxes saying 3 and it's 103, and that would be tachycardia. Okay? You just count your R waves. Take them times 10. Your PR relationships, there should be 1 P for every R or every QRS complex. So it should be 1 P for every QRS. All right, so your regular rhythm is going to be just kind of showing you across your R waves here again. That is going to be a regular rhythm where they are exactly spaced apart. Okay, yes. All right, so this is a 6-second strip. What is my heart rate if you count R to R? Perfect. Okay, so your rate is 80. You already have, see, check. You already got one of them. Okay, so then we're going to look at our rhythm. So the rhythm will come up, I think it comes up next. Yes. Okay, so your rate, too fast, too slow, or just right. That little half sheet of paper that I gave you, for those of you guys on Big Blue Button, can you see this, Kim, on there?
Yes.
Okay. The ECG sheets, the little half sheet of paper, or when you print it off at home, it'll be 2 on the same sheet. And you can grab these, Daylin, if you want. It has this right here. So with your rate, too fast, too slow, or just right. 60 to 100, where we want it. That's just right. If it's below 60, too slow. Above 100, too fast.
Down low, too slow.
Okay? Down low, too slow. Yep. All right, with your rhythm, is it regular or irregular? So when we look back at this one, if I were to put my fingers, kind of like calipers, on the R waves, would you tell me it's regular or irregular? Very, very regular. Okay, so when we start to talk about, we have more and more strips that we're looking at, that's exactly what I'll do. And I'll walk across there so you guys can see that. So when you are doing it on your test, and you take 2 fingers, and you're marching it straight across, you're like, oh yeah, that's very regular. But if one of them all of a sudden is a little wider, a little narrow, you're like, okay, this is an irregular rhythm. And that will start to tell you a lot once we get a little bit further. Your P wave, 1 for every QRS, and do they look alike? Okay, so we have P wave, P wave, P wave. Are they looking very similar? Is there 1 for every QRS? Yep. Okay, so we like them, right? They're likely coming from the SA node. They're a sinus P wave. Oh my gosh. I walk past that light, and then I'm like blind. All I see is green for the next few minutes. All right. Then our PR interval. So that's the 0.12 to 0.2 seconds, or constant. Constant can be unchanged. So we can say changed or unchanged. So when we're looking here, it's about one finger, what I'm looking up here on this board, that one might be just a little wider. So maybe they're about two fingers. Yeah. And so when you see that they're very much the same like that, and you have one P wave before every QRS that looks alike, that's an SA node P wave, or a sinus P wave. Okay, it's coming from the sinus node. All right. Let's see. QR complex. So narrow, less than or equal to 0.1, or wide. So when we go through our strips, we'll look at them and classify them as narrow or wide. So initially, when we're looking at our boxes here, and they're 0.04, or it comes out to be 0.2 for that box, right? Mm-hmm. So it should be half the box, right about there, or less. So these are nice and narrow, aren't they? There's your box. You see, and the QRS should not be more than 0.2 or 0.1. So they should be falling inside these little boxes. Some of these I've stretched, so they're a little hard to see how small they are. But this one, your box here, is the 0.2, because each one of those is 0.04. This should not be any bigger than 0.1. Okay, so from your QRS, from there to there, should be 0.1 or less. Now, if it's looking like it's pushing 0.15 or 0.13, I'm not going to split hairs. You will see when we talk about ventricular rhythms what I mean by narrow and wide. They're very obvious. Okay.
Wouldn't the width of that one be 0.4 or 0.04? Whatever it is?
If you were to measure it, oh yeah, if you were to measure it, it would
One
be
little one.
like 0.04. Mm-hmm.
Yeah. Okay, cool.
All right, and then your ST segment, we're going to classify it as elevated or depressed. So this ST comes right back up. You've got kind of that imaginary isoelectric line that's going right through here. And see how you have deflections above and below the line? So you look at your ST, and it comes right back up, and then goes nicely up to your T wave. So it's not hanging out low, so we wouldn't say that it's depressed, right? And it isn't shooting up high up here before it comes to the T wave. So the ST segment is not elevated either. So it looks, yeah. Not always, not always. But if it were to shoot above the isoelectric line, any bit here, and then have a T wave off the side or something like that, it doesn't have to go higher than the T wave. Yeah, if it's above the isoelectric line, if it comes up and it doesn't, and it kind of comes higher here, even if the T wave then goes higher, or if the T wave kind of comes off the side, it's called ST elevation if this isoelectric line, if it comes up above it. Okay, so I kind of keep going really high because you'll see that tombstone a lot. That T wave will come off as it comes down, but not always. So yeah, it doesn't have to be higher than the T wave. And then the T wave, is it inverted or peaked? So when we look here at our T waves, they're not inverted, right? Is it peaked? Does it look a little tall to you? A little bit. So what would you do? Check your patient. Absolutely. Check your labs. Check your labs. Because if you had a question, you're like, yeah, it looks kind of tall to me. I'm going to go look at my labs right after I look at my patient. If there's any question, check your patient first. Okay. Let's go to lunch. Yep.
Got my attention.
Yep. And then we'll come back 12:30 and keep going. Okay. Who is going to be in charge of telling me to record Blue Button? Okay. All right, Blue Button family. We're going to lunch. See you at 12:30. All right, let's see here. Pause my recording. Okay. Okay, you guys, here we go. You have full bellies. That does not give you permission to fall asleep. Hey, can't talk over you. All right. Okay, no sleeping now that you've had food and it's really warm in here still.
I love it. You look great acting. No sleeping.
Oh, did I?
If I see you falling asleep.
I think that violates the social distancing.
See, that must be guilty conscience because I really didn't look right at you. I don't think. Right underneath here, sweetie. That's okay.
I mean, I
Okay.
I'm just kidding. What are you recording?
All right. Yes. Yeah. All on my own. I'm so proud. I know. Sometimes we get a hang of this. Can you see on your computer what I see here?
I'm kidding.
Okay. All right. Welcome back to our Big Blue Button family too. Tell them hi.
Hi, Big Blue Button.
Hi. All right.
Hey,
With your electrolytes, yes.
Chelsea's computer just shut down, but she'll be back on as soon as she can.
Oh, okay. Perfect. Good to know. Good to know. Because sometimes, like when I went off before we went to lunch, and I scroll down who's on and snap pictures so that I can take roll. Because you guys are here and you've checked in on the QR code, but then we try to make sure that we give everybody credit. So, okay. This is empty on purpose. You do not have to know everything. Like magnesium can cause bradydysrhythmias and tachydysrhythmias and peaked T waves. And this is what I want you to know. Check your labs. If you see funky T waves or you see a dysrhythmia that you're like, I am not really sure why or what or how this would be happening, check those labs, okay? All of these here, your calcium and magnesium can cause dysrhythmias, but with your potassium, this hyperkalemia, peak T waves, and arrest. It can cause dysrhythmias that are lethal and big shifts in potassium. So that's why when somebody's really low and we're giving them IV potassium, we put them on a potassium protocol, which means they need to be on telemetry because we can start to see if any of those dysrhythmias are taking place. And there also is a protocol at how fast you can infuse that so that you don't just dump all this potassium in there and make that big shift. Okay, so that's empty for a purpose. You don't have to know which way those do. Just remember that they can affect it and that you need to check your labs if they're out of whack. All right, normal sinus rhythm. So this is what we're going to do with each rhythm. So if you look at the colored sheet that I gave you, or that you printed off or whatever, this one here, can they see that, Kim? Yeah? Okay, that one there. If you don't have one, come get one. I made some copies because I know not all of you guys have access to a printer or to a color printer or whatever. You will see across the top the normal sinus rhythms all in black. That means every piece of it is exactly the way we want it. And then the next line for bradycardia, only the rate is in red. Does that make sense? And so as we start to go through, you will find that each one of those has more and more red because there's more and more things wrong with it. Every single one we will walk through in this exact order. So it originates in the SA node. So your normal sinus rhythm is going to have, when we say SA node, you're going to look right here at your P waves. They're round and upright, and there's one before every QRS, and they're looking the same, right? Because they're all coming from the same place. They're all coming from the SA node. Our rate is going to be 60 to 100 because it's coming from the SA node. Our rhythm is going to be very regular. Our PR interval, if you come right here and look at this, it's unchanged. And the reason it's unchanged is because they're all coming from the same place and they all have an unchanged PR interval and one P wave before every QRS. And so they're all going to look the same, exactly the same when they're coming from the SA node. Then your QRS is going to be less than or equal to 2.1 or narrow. We're going to call it narrow. ST, you won't have any elevation or depression, and T wave will go the direction of the R. So when you look back at this, oh my gosh, it's a ways back. So let's go forward. Your R and your T will go the same direction. And your R and your T, same direction. And there's no peaked T wave or inversion. With your ST and your T wave, all of these basic rhythms that we're going to go through, they will never have an elevation or depression, and they will never have a peak or inversion while we're learning them. Then when we go to our practice ones and we do some practice strips, that's when you will see them, okay? So I'm not going to throw those wonky things in here while you're learning the rhythm. So right here, we're going to walk through these steps. So first I'll say, what's your rate? R wave to R wave. And then times 10. 70. Perfect. Because it's a 6-second strip. So you'll have little marks. Usually they're a little bit darker. Right here and right there. Okay, so our rate is 70. Are we in the 60 to 100 range? Yes, so we like it, right? Not too fast, not too slow, just right. Next, we're going to say, what's our rhythm? This is I'm kind of right in front of it. It's not very high. I'm trying to let them see it on there. Okay, so regular rhythm. Okay. Now look at the P waves. P waves. Round and upright, one before every QRS. Do they look the same? Okay. So that's coming from where? SA node. It's a sinus P wave. Are the PR intervals pretty much unchanged? Okay. So we're good there. Our QRS. We go Q, R, and S in a very small period of time, right? This box here is 0.2. So we're in about half that box. About half the box. So we're going to call them narrow or wide? Narrow. Perfect. Then our ST our ST segment comes right back up very quickly to that isoelectric line. We don't have any problems there, right? It's not kind of hanging out down here. It's not shooting up high, right? So we're good with our ST segment. And our T wave, not peaked or inverted, nice and round, one after every QRS and going the same direction, right? So what do you have here? Sinus rhythm. Yep. So that's how we'll walk through every single one of them. What's your rate? What's your rhythm? What's your P waves? What's your PR interval? What's your QRS? We'll walk down on every single rhythm. If you do that every single rhythm, every single time, then you won't miss cues. You won't miss different spots that will help you sort of diagnose your rhythm. Okay? All right. She is so cute. When someone asks you what you see, I don't know. But you will, I promise. Okay, So sinus bradycardia, or Brady, it originates in the SA node. So what's that going to tell you about your P waves? They'll all look the same, and you'll have a PR interval that is unchanged. And you'll have one P wave before every QRS, because they're coming from the SA node. And it's beautiful, exactly the way it should be, except our rate. Our rate is going to be the 40 to 60, and it actually should be 40 to 59, because once you hit 60, that's where we like it. So it's going to be too slow, too fast, or just right? Too slow, right? Then our rhythm is going to be very regular. And our P wave, round and upright, they look the same, one before every QRS. Our PR interval is going to be unchanged because those P waves are great and they're coming from the SA node. QRS, less than or equal to 2.1 or narrow. And our ST and T wave are not going to have any changes while we're learning this, but the T wave will go the direction of the R. All right, so causes for Brady dysrhythmias. The most common rhythm that's seen with an MI, parasympathetic stimulation, and vagal stimulation. So if someone is like little old people, they get constipated, they're straining really hard, they're taxing that heart, they have a syncopal episode and pass out. And then you find them with their pants down in the bathroom. Good reason to give them protons or something, right? So, and if someone's coughing really, really hard, it can vagal down too and slow their heart rate down. Nausea and vomiting. If someone's vomiting, like intractable vomiting, and they just keep vomiting and vomiting, they can vagal down. Hypoxia. If you have somebody that has an anoxic brain injury, someone who's a near drown, something like that, they will end up having a Brady dysrhythmia. Certain drugs will cause Brady dysrhythmias, and certain electrolyte imbalances will cause Brady dysrhythmias. All right, so what's your rate? 40, right? Because you have your R waves, and maybe I should do this so they can see me better. You have your R waves, and then you take it times 10, so it's 40. So too fast, too slow, or just right? Too slow. Okay. Now we're gonna, is it regular? Can you see? I don't know.
Yeah.
Okay, so is it regular?
Yep.
Yes, very regular. All right, and then how about our P waves? Do we have one before every QRS?
Mm-hmm.
Do they look the same?
Yep.
All right, which means our PR interval is probably what? Unchanged?
Unchanged.
Okay, so we're good there. Those P waves are coming from where? SA node. Because they're exactly the same. PR intervals unchanged. Nice round upright. One before every QRS. We love it. Our QRS. Okay, is it happening very small in this box here, right?
Mm-hmm.
And each one is 0.04. So we could take up a little bit further here. And we're good. So it's narrow. Okay, our QRS there is narrow. Now our ST segment. If you look at your isoelectric line here, does it come right back up, or is it kind of hanging out a little bit? Might be. So when it's a little bit slow to come back up and it's got kind of that little wider spot, if you're questioning, look at it more like a U or like a cup a little bit, and that'll kind of give you a good indicator if it's hanging out. This one is pretty close to coming right back up to where it needs to be. Very small gap there. And then it comes up to the T wave. T wave looks nice and round and going the same direction as the R. So our T wave is pretty good too, right? Mm-hmm. So there's only one thing wrong with this. What is it?
Good.
Sorry?
Brady.
Yes. Sorry. I can't quite tell sometimes where it's coming from with all the plexiglass up there. So yes, so it's Brady. So you just call it bradycardia. Okay. Signs and symptoms, it depends on the rate. They can have inadequate cardiac output, hypotension, shortness of breath, Level of consciousness change, decrease urine output, and they can be cool and clammy. So think about this. You have a heart that is beating very slow. Are we going to be getting a lot of blood flow out to the body? Nope, because it's beating very slow, right? So that's our inadequate cardiac output. If you're not getting a lot of blood out to the body, will you be perfusing okay? No. And if you're not perfusing well, what's your level of consciousness going to be like? Not getting a lot of blood to the brain, so it could be decreased, right? They could be a little bit short of breath. Hypotensive. We're not getting a lot of blood out to the body. Okay? Decreased urine output. We're not perfusing those kidneys. So we're not going to get the urine output that we want, and they could be cool and clammy because they're not perfusing. So when you think about how the clinical manifestations, that's what that is. Okay, so when you look at your objectives, you're like, what are the clinical manifestations of that? I don't even know. That's what it is, your signs and symptoms. And why is it looking like that? Because that will lead you down to what are you going to do about it? So your interventions, none unless they're symptomatic. Anybody have a low resting heart rate? Used to. Who said that? Used to. Yeah.
So I've heard of like athletes have like really low resting heart rate.
Very much. Yep. Very much so, especially swimmers, distance runners. A lot of those very, very athletic people can have a very low resting heart rate, can fall below that 60, can fall below 50. My mom has a resting heart rate of 47. Every time she goes in for surgery or something, they freak out. They don't want to let her go home. I think you need a pacemaker. She's like, I'm sitting here talking to you and I'm just fine. My daughter said, if I'm not symptomatic, I don't have to stay. They're like, I want to talk to your daughter. So the fact that she knows symptoms, if I'm not symptomatic, I don't have to stay. So symptoms can be syncope. They can pass out. Angina, have some chest pain, dysrhythmias. They can give medications to increase the heart rate, to hold digoxin. Digoxin is medication you'll learn more about, but it can slow heart rate. Relieve nausea and vomiting, but it can be normal in athletes. So when you think about your BLS and you think about when you do compressions can be less than 60 if they are symptomatic. Okay, so if you have somebody sitting there talking to you and they have a heart rate of 52 and they make sense and they're perfusing, and please don't start compressions on them. They will be very angry at you. So this is symptomology, this is symptomology. These are your interventions if they are symptomatic. Medications, so atropine, I always remember the T, 2 speed up. Okay, so atropine, 2 speed up. It blocks vagal stimulation, and that is one of your front lines for bradycardia. They can also give dopamine and epi. I like to give you just a look at this so that you see how it dovetails with Corby and Debbie's class. I will not ask you drugs in my class. That's what pharmacology is for. But we try to mention some things more than once so that you hear it more than once. It just helps. So just remember your atropine is 2 speed up. Other treatments, they can put in a pacemaker. So when we do our little pacemaker part of our unit, I think it falls next Monday, there's a little video that we watched in there of a guy that had a pacemaker placed because his resting heart rate was like 38. And he was having a little bit of dizziness, but that really was his only symptom. And they found it because he went in for a routine physical or something like that. He was retiring and went in for a physical, and they found that he had a resting heart rate of like 38. So they put in a pacemaker because you just don't have much leeway for trouble, right? If you miss a beat or two when you're only running at 38. Okay. Tachycardia. So bradycardia makes sense? Okay, so next one down on your little sheet there should be tachycardia. Or tachy, you'll hear it all those ways. Sinus tach, or they're tachy, you'll hear all of those terms. It originates in the SA node. So what's that going to tell us about our P waves? Nice and round, upright, 1 before every QRF, right? Okay, then our rate, 101 to about 179, and I'll tell you why that's kind of the ceiling, because it tips to another diagnosis, I guess, at that point. The newer American Heart Association guideline, I need to change this to about a 159. Yeah.
Well, it's 149 on the paper.
Oh, is it? Oh, perfect. Okay, I knew I changed it one place, just didn't change it twice. So you can put 101 to 149, and that's a newer American Heart Association guideline. It used to be that they didn't diagnose SVT or supraventricular tachycardia until it hit about 180. But now they're saying over 150 with certain causes and certain symptomology can be classified as SVT, and we'll talk about that. So for simple tachycardia, go by what's on your sheet. Go by what's on your sheet, the 149, okay? If I were to give you a test question about it, I have checked my test questions, and it will be, if there is something that's SVT versus tachycardia, then you will have the information you need to make that differentiation, okay? So the rhythm is regular. T wave is round, upright, one before every QRS, and so our PR interval is going to be unchanged because it's coming from the SA node, and our P waves are fine. Our QRS, less than or equal to 2.1 or narrow. Our ST segment and our T waves are going to be just fine while we're learning this, and the direction of the R wave is your T wave. Okay, so we'll look here at our causes. There's a whole host of causes. So instead of like memorizing each individual, just think about what gives you a fast heart rate when you're kind of anxious, when you're a little dehydrated, when you've been exercising. There are some kinds of diet medications that have sort of an amphetamine type reaction. There used to be one years ago in the 90s, I think, called fen-phen. Those of you guys that are a little closer to my age, there might be one or two of you that I had a really good friend that was taking fen-phen, and they found that it could cause damage to the heart valves. One part of that, so there was like a phentermine and something else, I can't remember, but they were both called fen-phen. Anyway, so one half of that can cause some problems. Well, she already had a valve problem, and so she went in to see if her heart had been damaged or anything, and nothing had been damaged, but they took that one half of the medication off the market. And I don't know if the other half is still a diet medication. I don't know if anybody knows that, but the half of it was damaging their heart. So you can have, I think on here, I used to have diet medications, but stimulants. So if you give somebody a stimulant, they're going to be less hungry, right? And so that can be part of that too. Yeah.
So it's normal to get your heart rate like up to like the one, like this range when you're in exercise, like this nothing.
Yes. So yes, very good question. So if your target range for your heart rate is up there while you're exercising, that's fine. But if you were to sit down and settle down and it didn't start coming down as you're walking it off, and you're done swimming or you're done running, usually it's good if you've run a long ways to go ahead and take a walk around the block or around the track or whatever and kind of slow it back down. If it's not coming back down, then it would be classified as tachycardia, but the cause would have been exercise.
Okay.
So if somebody comes in and they say, I was running and this and that, my heart rate was up and now it's just not coming down, the exercise might have been the factor that started it, that kicked it off. Okay. Anxiety, pain, hypoxia. Hypoxia, you will more often see later hypoxia will cause bradycardias. Early on, like if somebody is having an asthma attack or something, and they're having some hypoxia with that, can cause tachycardia. But as it gets further and further and they get more and more hypoxic, then they will start to brady down, and that will slow their heart rate. So don't be confused when you saw that in the symptomology for bradycardia. That's a little bit later. That's more hypoxic, okay? This is more initial. Hypovolemia and hemorrhage. So if you don't have enough blood and you don't have enough volume, your heart has to beat faster, right? We don't have all this volume to be pumping around, and so that heart has to beat a lot faster to get everything to move. Okay, so what's your rate? 140?
Yeah.
Sorry, I didn't count as I was doing. 140, I'll take your word for it. All right, so counting those heart rates. All right, this is a little higher, so it's a little easier. Is it regular?
Yeah.
Okay, very regular. And then what do our P waves look like? So P wave, one before every QRS,
Yep.
looking very similar. Okay. PR, yeah, some of them are a little more wiggly than others, right? What about your PR interval? Basically unchanged here. Some are a little bumpy, but your width is what you're looking at here. About a finger. Okay. QRS, narrow or wide? Narrow. Okay, because we're falling in within our box, right? So it's narrow. And then what about our ST? So it doesn't come down real low, but if you look at your isoelectric line that's kind of running right through there, it's not coming way above or way below, right? So our ST segment looks okay. And then what about our T wave? What do you think about it? Anything? Does it look okay? It looks a little tall, yeah. And so if you were wondering and you were questioning, what would you look at?
Electrolytes.
Electrolytes, there you go.
See that?
Perfect, go look at your labs. Go look at your labs. All right, so for all intents and purposes, there's really nothing wrong with this one except maybe possibly a peaked T wave here other than our rate, right? So what would you call this? Just, yeah, sinus tachycardia or tachycardia. But sinus tachycardia is a little more correct because we have those sinus P waves, okay? And you could say sinus tachycardia with a peaked T wave. And that's what a lot of the questions on the test will be, like a two-part like that. That it might have an elevated ST or an inverted T wave. Or it might be a normal sinus rhythm with a PVC or something else that we'll talk about. Many of them are just a two-part. When we get to our practice strips, some of them are 3 or 4-part because I couldn't find the specific thing that I wanted in a practice strip that didn't have other things also. But on your test, you will not have 3 and 4-part strips. 1 or 2, okay? Yeah.
So did you say you'd call this one sinus tachycardia with elevated T wave?
Sorry?
Would you call it an elevated T wave or
Or peaked?
peak?
Yeah.
Okay.
Elevated and depressed will be more your ST segment,
Okay.
and peaked and inverted is your T wave. But if you mess that up and said an elevated T wave, everyone's going to know what you're talking about anyway. Okay. So signs and symptoms of tachycardia, it's not usually significant unless there's underlying comorbidities. So if you come in and you've been exercising or you were just in a car accident or something like that and you come in, we would expect you to probably be pretty tachycardic, right? Especially if your anxiety is kind of up, something initially has happened and you're really nervous. Maybe you had an asthma attack and so it was already kind of going kind of fast and then you took your albuterol and that's going to ramp up your heart rate. And so if there's a reason for it that isn't causing other problems, then we would hold off some of our interventions to see if it starts to come back down. So if you came in after a car accident or if you came running in after exercising saying that you felt like you were having some heart palpitations, then we would want you to sit down and calm down and we would see if that would start to slow down before we would give you medication to slow it down, okay? It can cause angina It's often seen. So myocardial infarction can be if they have had an MI previous and caused ischemic changes. Then with that ischemia, you can that's a comorbidity. So then you can see some tachycardia. But if they are having an MI, it is most common to see bradycardia. So that's why on the bradycardia side it said most commonly seen with an MI. Congestive heart failure, or if they are in shock. Now, if they're in shock, why would we see tachycardia? Compensation? We don't have a lot of volume, or we're hemorrhaging, or something like that, right? We're speeding up that heart rate. Okay, they can be diaphoretic and anxious, have a decreased filling time, so which is going to then go into your stroke volume and your increased workload. So you have a decreased filling time. You have this heart that's doing this. Does it have a lot of filling time? I can't stand with this hand very good. It's a left-handed thing. I can't stand with my left hand. Decreased filling time. So it's cooking along really fast, right? And we just don't have a lot of time to fill those atria and ventricles. So then you don't have a lot of cardiac output to push out to the body. That's your decreased stroke volume. So you don't have a lot of volume with every beat of that heart. And so it's going to increase the workload on the heart because you don't have the filling time. It basically comes back to not having enough blood flow and your filling time. So if you're not having a lot of filling time, what other signs and symptoms might you see? If you had decreased cardiac output, would it be similar to bradycardia and what you would see? Yeah, because you don't have, it's a different problem, but you're still not having the cardiac output that you really need, right? Now, if you're compensating well, maybe you've been exercising and now, and so your body's compensating, but it's been really tachycardic, and now it's starting to slow down, but you're still compensating very, very well for what had been a higher heart rate, then you're not going to be symptomatic as symptomatic as someone who maybe is on medications like stimulants or something like that, that's perpetuating that heart rate, that we need to really intervene and do something about. So interventions, none unless they're symptomatic. Don't you love that? And then give meds to decrease their heart rate. Like, no interventions, check. I'm good. Ask me that test question. No interventions. All right, so meds. Adenosine, so with your S, slow down. So your atropine is 2 speed up, and your adenosine slows down. They can also give calcium channel blockers and beta blockers. The beta blockers are often for patients with MIs. But Corby will go more into that, or Debbie, I'm not sure who's teaching that lecture. Other treatments. Treat the underlying anxiety with meds or relaxation, helping somebody kind of bring it down, talk them down, or if they have a panic disorder or something, helping them out with medications to help bring that down. Fluids for dehydration, so that we get more volume in there, right? Antipyretics for a fever, because if they have a higher fever, they're going to have a higher heart rate. And then antibiotics for sepsis. So with sepsis, a lot of times their blood pressure will be in the toilet. And if their blood pressure is low, what's your compensatory mechanism? Fast heart rate. Yeah. So they do this. Your body's trying to compensate for that low blood pressure. So if you think about back here, when I say clinical manifestations of tachycardia, then you're like, oh, okay, this is what it can look like. And what do I feel like when my heart rate's really fast and really moving along? I might feel a little anxious, even if anxiety wasn't the initial cause, right? Because you might have a little bit of heart palpitations, or you might just feel like, oh, my heart is really racing. It's going really fast. And so sometimes people will be short of breath. They can get dizzy because of the cardiac output being less. So then I say interventions, okay? We're going to say they're symptomatic. So then you're going to look at your meds and your other treatments. Think about what's causing it. What's causing that tachycardia is going to be down here, and this is how you will intervene. Somebody taking my chairs away. Okay.
They got a ladder.
Okay. It's like, it's too dang hot. You can't take my chairs away. All right. So funny. It'd be a great little Valentine, right? Your brother looks like him? Yeah, I always forget who it is.
Ryan Gosling.
Okay. Plays what?
Notebook, the
Noah in
Notebook.
the Notebook, and he has a dream.
In the Notebook. That's right. Everybody tells me every semester I should watch that, and I always forget. No, I should. But I'm a big ball baby, and I've heard that you will need a full box of Kleenex. Your husband cried. Oh,
Yeah.
that would be interesting to see if mine would, because mine doesn't. Like ever. All right. Are we good so far? Bradycardia, tachycardia. Okay. All right, a sinus arrhythmia. So this is just an arrhythmia. It's not necessarily too fast, too slow. It's going to be irregular. But what kind of irregular? Regularly irregular. Okay, so that's the one that there is a pattern. And the pattern doesn't change. It's an irregular pattern, but it's always the same. Like my husband has an irregular heartbeat. It's always been the same for the whole time I've ever known him. And it's just beat, beat, a beat, 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 a beat. Like the third one is always that little double beat forever. Like I've never known it to change. And you can even feel it in his pulse. Like at first I was like, when I first noticed it, I was like, oh, wait, okay. So I had my ear on his chest. I was like, wait, let me go get my stethoscope. I got my stethoscope and I put my finger, I'm like, you can feel it too. He's like, cool. But no, it is. It really is cool. So,
Bringing him in so we can listen.
yes. So this is very phasic. So I'll tell you what I mean on the next slide, what I mean by that. So it originates in the SA node. So that's going to tell you your P waves, right? They're going to be nice and round, upright, one before every QRS. And that's going to make your PR interval unchanged. Okay, because they're all coming from the same place. We like that the rate is 60 to 100. So even though it has these little changes that are very regularly irregular, the rate itself doesn't necessarily go above 100 or below 60. Yeah.
Maggie Birmingham just had a question. She said, are there going to be medication specific on the cardio test?
Not on my test. I won't ask you medications. So an intervention might be medications, but I won't ask you if it's atropine or if it's adenosine or if it's epi or whatever. That'll be pharmacology. Thank you for watching that. So our rhythm is going to be regularly irregular. P waves PR. So then our QRS, less than or equal to 2.1 or narrow. Our ST segment, no elevation or depression. Why is that?
People are walking upstairs.
We are upstairs. Oh, out there. That's so weird. Okay. Anyway, so then your T wave is going to go the direction of the R wave. Yeah.
So in another class I took, I think it was physiology, they said that it's actually normal for you to have like a little bit faster heart rate, like when you're breathing in versus like breathing out.
Perfect.
So the
exactly what
article
this
says
is.
that the sinus arrhythmia is just like the changes with breaths. So
Yes.
does that mean that that's like bad or good?
No,
Okay.
it's actually very normal, especially in a pediatric patient. And so when they are breathing, if they're breathing in and out and in and out, and you have a very calm child, you can notice it more in them. But even in some adults too, if you put your stethoscope on and listen to them and feel their heart rate, or put your hand on their back to feel their breathing and listen apically, you can find the correlation with this often. So when they breathe in, so here we go. So it's irregular changes with breathing. It's very phasic. So with inspiration, the rate increases, and with expiration, that's probably not the best way to say it for the cardiac patient. When they expire, when they breathe out, the rate decreases. So you will be able to see right here. So what's your rate? 60. Perfect. All right. And then your rhythm. So I'm going to go here Okay, so we have one that's kind of missing there, right? So then if we left off from here, now it's going to be kind of missing again. So if we started here, then so we've got this little wider spot right in between here. See how that looks the same as that? But then we've got this little spot in here that's longer. So if you were to watch this patient breathe, then you could see them breathing in and breathing out, and breathing in and breathing out. And you would find this correlation with it, and it would be very phasic and very regular like that. Yeah.
So I guess then my question is, like, if that's fairly normal for that to happen, would you call that sinus rhythm, or would you call that sinus arrhythmia?
A sinus arrhythmia.
Okay.
Because
but
it is
like a normal sinus arrhythmia.
Yeah, I don't know that I'd put normal in there. I would just say sinus arrhythmia.
But you just
Sinus
like aren't
because-
worried about it.
Right,
Okay.
right. There is no intervention needed for this because they're not symptomatic. It is very normal, even though normal sinus rhythm is the only one we really give the word normal to. This is very common
Okay.
in pediatric patients and then in some adults too. But if we finish and we walk through the rest of it, it's a little bit choppy. I had a hard time finding one that was just a sinus arrhythmia without a lot of artifact in here. So this is usually somebody who's moving or has a loose lead. So that's where it gets kind of really thick and dark and kind of choppy. But for most, like all intents and purposes, we have a P wave here and P wave here. They look very similar, right? So they should be coming all from the SA node. Now we have one before every QRS. And do we have a pretty unchanged PR interval? It's about 2 fingers. And do we have a narrow or a wide QRS? Narrow, okay. And our ST segment, looking pretty good there. Okay, T wave, looking okay there, right? And going the same direction as our R. So really our only thing that's off is that rhythm a little bit. And so if you noticed that when you were listening apically, take a good 60-second apical pulse and pay attention to their breathing at the same time. I've had students go home and come back and be like, my husband totally has that. Or my kids, I did it while he was sleeping, and that really is something. All right, so interventions, nothing. Just normal with respiration. All right, so a sinus pause. The rate, usually normal, 60 to 100. However, if they start having a lot of pauses, then could it drive that heart rate below 60? Yeah, because if you have 60 and you have a pause, and then a couple beats later you have a pause, and a couple beats later you have a pause, pretty soon that 60 heart rate is not going to be 60 anymore. Okay, 58, 50. So they can end up being bradycardia with a pause as opposed to being sinus with a pause. Does that make sense? So your rhythm is irregular due to the pause. So they can have a very regular rhythm, and then they just have this pause, and it actually can be kind of long. It can be disturbing how long it can be. So you have your P waves. So it's not sinus. I'm missing. So my P waves are round and upright, one before every QRS, because it is still coming, there is still a sinus rhythm to it. It just happens to have this big pause. So our PR interval is going to be unchanged. QRS, less than or equal to 1.1 or narrow. And then our ST segment and our T wave won't have any changes, and our direction of our wave will be our T wave. So causes can be recent heart surgery, and that heart's just kind of trying to get up and going again and kind of find its rhythm. Underlying congenital heart disease. So you will find in some of these babies that we talk about that have the congenital heart problems, a sinus pause is not something that's uncommon for them. And then parasympathetic stimulation and age. The older they get, the more common it is to have AFib and other dysrhythmias and pauses and PVCs and all kinds of stuff. That heart's just getting tired and getting older. Okay, so what's your rate? 50. Too fast, too slow, or on time? Too slow. So we already have bradycardia. Okay. Then what's your rhythm?
Missing.
And then it would go right back. See how it kind of just misses one right there? Okay. But for the spot that we have, these here are looking okay, right? And then we just have this big open area here where we completely paused or missed a beat, and then it picks right back up. So we would call it irregular because of this area. Now we have, let's look at our P waves. Round and upright, one before every QRS.
Yep.
Do they look pretty similar?
Yep.
Okay. Did somebody say no? Oh, I thought somebody said no. I was like, really? Okay, PR intervals. They're looking the same?
Yep.
All right. And then our QRS didn't go very low, but it's still kind of at that isoelectric line, so that's okay. It just dipped and came back and didn't hang out low or come up high. So we're okay with our ST segment. Does our T wave look okay? Go in the same direction like it should be?
Yeah.
So then we just have to address what's going on here. Nothing, right? Got just this big pause. So what would you call this? Sinus bradycardia with a pause. Yes. Okay.
You are a complex a little wide, or am I just like?
This one, and it still falls, see your box here? So it may look a little wider than some we've looked at, probably because I've stretched it to be big and nice for you to see. But you've still got, it's still within that box there from the QRS.
Gotcha.
Interventions, surgery for congenital heart defects, and sometimes they need a pacemaker or long-term antidysrhythmics. Okay, wandering atrial pacemaker. So you'll find on your sheet that I gave you that there starts to be more red, more and more red as you work your way down the page. All right, so it originates in the SA node or the atria or the AV node, somewhere up there. But if you notice, all of those are above the ventricles. If they're above the ventricles, they will always have a P wave, because that's atrial depolarization, right? If we have a P wave, then that is not ventricularly driven. We have atrial depolarization. Now, where in the atria this is coming from, we don't really know. We're going to find that they look different, but it is coming from the atria nonetheless. The rate, it's usually 60 to 100. But it can be different, so we will look and see as we go, which ones we've got, which one we have lined up. The rhythm is just slightly irregular because it's not all coming always from the SA node. You might have a couple from the SA node, a couple from the atria, and some from another spot in the atria. And you will find that you have a couple of P waves that look the same. Oh, that one's different. Oh, that one's even different than that one. And now we're back to the same ones that we had before. And so all the ones that look the same are coming from the SA node. And then you might have a few hiccups in between that are coming from other areas of the atria. Let's see. P waves, so upright, different shapes. And there still is only one for every QRS, though. Did you raise your hand, Caitlin?
No.
Oh, okay. Sometimes I see a glare from.
That's okay. I was just wondering the difference between the pause and the block though, because they're so similar.
They are similar, but we're not going to talk about a block here. They are similar because you drop a beat. And so if you're getting longer, and then you drop a beat, it's a type of heart block. So you're exactly right on with that. They just don't have to go into that until they do RN3.
Sorry.
Yeah, no, you're good, but you're right on. that is the type of heart block where you, your PR interval gets wider, 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 and then all of a sudden you drop a beat. So, PR interval will vary. Why will it vary? Because what? I kind of hear mumbling.
Where it originates?
Yes, because where it originates. So even though we have P waves, they're coming from different places. And so they are going to have, so they are good. We're like, oh, I think that's the same as an air fist bump, right? Plexiglass fist bump. Okay, so yes, that's exactly why it'll vary. QRS will still be narrow because we're still coming from above the ventricles, right? Those are atrial impulses. And then our ST and our T wave will be fine for now with the direction of the R wave, our T wave going the direction of the R wave. So causes just a different foci or focal points, this is plural for focal points, within the atria, along with the SA node. So you will see some that all look very similar, that all seem to be going along just exactly the way they should be. Varying vagal tone. So if they, the higher the vagal tone, the less the SA node fires. So if they are vomiting and vomiting and vomiting and vomiting, then that SA node sometimes will fire slower. And then other parts of the atria will be like, whoa, wait, we should have had an impulse. And somebody else is like, whoa, don't steal my thunder. And so then they've got these different impulses that are coming throughout the atria.
Is that like an electrolyte imbalance from vomiting, like with potassium? Or?
Yeah, so then you can be hypokalemic because you're vomiting and diarrhea and you're really sick, and then that can throw off your potassium, which will further your complications. Yeah. Yep. See, I love it when you guys start making these connections. Okay. COPD, they also, because they have chronic oxygenation issues, can start to cause the SA node to be what they call sick sinus. And so they don't have, it doesn't fire as much as it should. And so different parts of the atria will try and take over. Only one focus initiates at a time. So even though you have the SA node firing and other parts of the atria firing, they don't all fire at the same time. So you won't have multiple P waves. Okay? And the P waves change in their configuration. Okay, back to the same picture we saw before. That makes me a little crazy when it keeps bouncing. All right, so here we have SA node. We're going along, so we've got these nice P waves. That one's a little shorter in here. Then it dumps down here. Then it's got the notched bunny ears there. So when we go looking through here, does that look like a nice sinus rhythm? So those are probably SA node because they look very, very similar. Then this one is shorter. See how it's closer? And so it very well could be coming from a different spot in the atria. But we know that it's still atrial because it's above the ventricles because we have a P wave. If you have a P wave, it is always above the ventricles where that stimulus is coming from. So sinus or atrial every time. Okay. Also, if you have a narrow QRS above the ventricles. So you can say, even if you were like, whoa, I can't really see that I have any P waves. Like if you have AFib or A-flutter or something, you're like, I don't even know if that's artifact or if those are P waves or if I have a lot of them. Then you look at your narrow QRS and go, yep, okay, then there's probably P waves in there and I just got to look for them because if I have a narrow QRS and my T wave is going the same direction as my R, that's another good indicator that it is not a ventricular rhythm. Okay. So then we have these two that look the same. Nice sinus P waves. This one probably coming from a different spot in the atria, another different spot, and another different spot. And then it may very well go back to here, or maybe it jumps back to the one that's dumped upside down. But then you just can see that even though it's very regular, according to the R waves, they're coming from different impulses. Okay, not all from the SA node. Okay, so what's your rate? 60. Too fast, too slow, or on time? Perfect. Okay, and then. Alright. That one's a little bit off, right? A little bit closer. Maybe my hands got wetter as I went, I'm not sure. But it's pretty regular, right? We don't have issues with it being very irregular that we're concerned about. All right, then how about our P waves? Is there one before every QRS? But do they look the same? No.
I like that one.
You like that one?
Thinking about flat line.
And then picking out the ones you like. I like you. All right, so when we have, so now we know we have an issue with our P waves. So just tuck that in your pocket for a minute. Now go to your PR interval. Is it different each time?
Yes.
Okay, so another indicator that this is not coming from the same place, right? Okay, QRSs. Are they still falling within a box here?
Yeah.
Yeah. So we're still going to call them narrow. Even though they look a little wider than some that we've looked at, they're under that 0.1. Okay? All right, then our ST segment, looking okay, right? What about our T waves? They're kind of tall, huh? So if they're kind of tall and you're kind of concerned about that, what are you going to look at? Electrolytes. Perfect. Okay, so now we know that everything's looking okay. We're in our 60 to 100. There are no issues with anything except that P wave that's looking different and coming from a different place. So what would you call this? Wandering atrial pacemaker. And that's it. With a peak T wave, if you're thinking that that's higher than you like. But it will not be questionable on your exam. It'll either be peaked or it won't be peaked. And it will be very easy to identify, okay? All right, so your wandering atrial pacemaker interventions, most patients are asymptomatic and they don't require any treatment. Now, if they start to have a lot of changes, then that can start to lead them down the path of where they have too many P waves because they start firing on top of each other, and then you have too many P waves. So sometimes people will see this if they've been hooked up to an ECG or telemetry or something. Sometimes they catch it when they go in for an elective surgery. And when you get a little bit older and you're going in for elective surgery, they just like to do like a stress test or an ECG or labs or things like that. So they pick up on any problems that you might have underlying that you didn't realize that would hamper your recovery. And so I've seen patients that have come in for tests and they pick up a wandering atrial pacemaker and they're fine. And they're physically fit enough to be able to have an elective surgery, but they just happen to notice this. I thought this was so clever. It is very much nursing life too, not just med school life. And I wish I came up with it, but I did not.
Sorry.
Yep. Isn't that clever? That's a lot what you feel like, huh? What's that? Go back to bed? Yeah. All right, atrial fibrillation or AFib. We'll do this one and then we'll be done. Okay, done. Hang with me.
Wait, sorry, I have a question. So like with the wandering atrial pacemaker, if they get, so they have a lot of changes, it could become like too many P waves, then what does that mean?
If they start to have too many P waves, then you push being into atrial fibrillation or atrial
So
flutter.
we're gonna talk about that. Okay,
Yeah.
sorry.
Yep, we will. And if they start firing on top of each other, then you're going to decrease your cardiac output because you have all these firings, atrial firings, and only a few QRSs that are getting through to that impulse.
Okay.
Yeah,
Sorry.
good question. No, you're good.
Your battery's running low.
Oh, man. I didn't bring my cord. Hell's bells. Yeah. Except I don't know like how low is low.
remember the little battery at the very bottom of your laptop?
Well, when I'm in this screen, I don't know. Okay. Kim's going to tell me if we run out and then we'll do it over, but we're going to try and hit AFib. Okay. If it goes dead, then we're done. Okay, so it originates in the atrium. The rate is variable. So your atrial rate can be like 400 to 600. Who can count that, right? What? You're just going to see a ton of P waves. But your ventricular rate can be normal or tachycardic. So this is where I said we're going to count our R to R for our rate. We're not going to count our P waves for our rate because that can get a little crazy and get a little tricky. And it means more when you're talking junctionals and heart blocks. For this, we need to just, it's very much easier. That didn't come out right. Now I can't even say it. It's easier to do it by your R waves. Okay? Your rhythm, it's irregularly irregular. So here's the difference. You have AFib and A flutter, and one of the key ways you can tell the difference is about 95% of the time, atrial fibrillation will be irregular. Likewise, 90% of the time, 95% of the time, atrial flutter will be very regular. Are there instances when they are not? Yes. There will always be those anomalies. But if you were sitting the fence and you were like, I don't know exactly which one this is, I'm going to give you some ways to look at the differences, but that is one of them. That AFib is very commonly irregular, and there isn't a pattern to it. Your P waves, many small fibrillatory waves. So fibrillatory is not pumping. It's just vibrating. It's just fibrillating like this. It's just shaking. Is that going to fill your ventricles very well? Nope. Nope. Nope, it's not. So your PR interval is going to be not applicable because you have so many P waves. And your PR interval goes between a P and a QRS. So if you have all these P waves and a QRS and all these P waves and a QRS, it's not going to make any sense to even worry about a PR interval. Your QRS will still be narrow because where is it coming from? The atria, right? So we're above the ventricles. We will still have a narrow QRS. Our ST segment and our T wave, they'll be fine. And our T wave is difficult to see with all the P waves. Now, T waves are a little wider and rounder, so they still kind of look like rolling hills. So sometimes you can still identify them. Sometimes they get lost in all the P waves. So you remember what happens when we talk about a P wave and a T wave and they land on top of each other? And you can throw somebody into a lethal dysrhythmia. So if somebody's having just a gargantuan amount of P waves, is that potentially a risk? Mm-hmm. Yeah, because your T wave is here while it's already picking up with P waves. Okay. AFib, there's a lot of causes. One of the really, it can be idiopathic. This is really common. The older someone is, the higher their chance of having atrial fibrillation. And sometimes they don't even know where it comes from and why it's there. Their stress test is fine. They don't have congestive heart failure or coronary artery disease. I mean, most people that are older have a little bit of coronary artery disease, but nothing that's significant enough to maybe be the causative agent for this. Pericarditis, if they have inflammation, they'll lighten up their heart. Hypoxia. If they have alcohol, carbon monoxide poisoning, and hypokalemia, alcohol is usually significant, like alcohol poisoning is going to cause this kind of change. Not just like if you go tie a few on over the weekend, sometimes binge drinkers that really are at risk of stopping breathing, and they've been passed out for a long time and friends bring them in or something, you will find that they're in AFib. But it isn't something, once the alcohol's out of their system, you will start to see it resolve. Sleep apnea can cause AFib. Yes. Yep. Okay, so what's your rate? Yeah, I think there's one sneaking in on the end there, huh? So 80, all right. And so we'll just start here with our regularity. And so then maybe we'll try here. Okay, so we'll go back to here. So there really isn't a pattern. So it's just irregularly irregular. You don't have to say it like that. You can just say it's irregular. Okay, so we know that we're 80, so we're in our 60 to 100. So we're okay there, right? Sometimes your R waves, sometimes your QRSs can be tachycardic. Sometimes they're just in the 60 to 100. And only the P waves are tachycardic, or only the P waves are going too fast. So you have atrial tachycardia is basically what that is. All right, so P waves. We've got several in there, and you probably have more in between. And you see all those little ones in there? How it just looks shaky, right? Like it's just fibrillating, just shaking in there. And then you have a narrow or a wide QRS. Narrow. And your ST segment? It's fine. Okay. And then how about our T wave? We can see some pretty nice T waves there, right? But look at that. Kind of sneaking in between there. And then our T wave is going the same direction as our R. So the only thing that's wrong, it's irregular, and we have a ton of P waves. Sometimes you will just see kind of this wavy little bass line through here. And I will show you some different pictures of atrial fibrillation so you can kind of see it when the amplitude is up and they're a little bit taller and you see more P waves, or when the amplitude is lower and it just looks like this wavy little bass line that has little scribbles in it. If you were to wonder, like when you're looking at how shaky this is and a really thick black line, if you wondered if that was artifact or if that was AFib, what would you do? Check your patient. Yes, I love it. Who said that behind the mask? There you go. Like I can't see anybody's face move. Okay. Yes, check your patient. Because you may go in there and find that they're laughing and they're messing around and they have a loose lead and it's rubbing on their gown. And so then it's like shaking everywhere.
I feel like this happens a lot when parents will like pat their baby.
Oh yeah.
They're like, please stop.
Please stop. Don't do that. But if you go in and you see that, you're like, oh, okay. Then just make a note so that other people see your note and go, oh, okay. We've seen this a couple of times and the baby's been checked on. I'm just going to double check, make sure it's the same thing. But yeah, you can always check your patient. Okay, so I think, oh, okay. So we'll come back to that. We'll start right there. We'll end on this slide. What slide number is this? 66, okay. Yes. It's okay. It'll be okay. Who was like 66 out of 120? I promise it'll be okay. All right. So tomorrow, quiz at 8. And those of you guys that are taking it online, be ready at 8 o'clock. That's when the quiz will open. And then it'll close at 8:15. And then just jump on blue button. We'll give you a few minutes to get on. And then we'll go over the answers. And then we'll jump off into our lecture from here. Okay? All right. Good work. Yeah. The quiz is on the cardiac assessment. Okay, so not ECGs, nothing ECG related off this PowerPoint. The first PowerPoint and like your health assessment. So, and not even really your big health assessment, a baseline assessment. And if you have questions on it, look in your book about your basic baseline cardiac assessment. Pretty easy, simple questions, not like your big drawn out story questions that we have for exams. Sorry, what?
Go.
Oh no,
Here in class. Critical thinking.
thanks you guys. We'll see ya.
And there's a hike today at 3:30. Waterfall Canyon.
Oh, really?
Yes.
That's very cool that you guys do that. Are there several of you that do that?
Yeah.
Ah, very nice. All right, I will see you guys tomorrow. Hopefully we see more of you in class because it is very good plexiglass bank teller type seating.
You are currently the only person in this conference.